Good morning, sir. Good morning, Dr. Salim. Good morning, Dr. Somesh. So we are live. Should we start the session, sir?
Good morning, Dr. Madhuri.
Can we start the session?
Yes, sure.
Okay. So we have gone live, I guess, Shweta?
Yes, ma'am.
Yeah, okay, great. Okay, good morning, dear friends. We are all excited on behalf of our organizing committee from Mumbai, Pigmenticon 2022. It's a pleasure to have you all, and we're starting our vitiligo surgery with the doyens out here. I'm handing it over to Dr. Yuti Nakwa and Dr. Prateek Thakkar, the host of our day. So over to you, Dr. Yuti, and wish you all the best and looking forward to a great session.
Good morning, everybody. I'm so pleased to invite everyone for this wonderful morning session of vitiligo surgery. We have with us esteemed faculty members, Dr. Somesh Gupta, Dr. Madhulika Mhatre, Dr. T. Salim, Dr. Deepak Mohana, Dr. K.T. Ashik, Dr. Sumeet Gupta, and Dr. Mukesh Giridhar. As we begin the session, I would like to inform all the delegates who are participating that if during the session, we'll be playing the presentations with live demos. And if you have any queries or questions, kindly write to us in the chat box, which we can address to the speaker at the end of the entire talk. So kindly sit back and enjoy the workshop. And let me begin with the first talk. The topic is Introduction and Overview of Vitiligo Surgery by Dr. Somesh Gupta. Sir is a professor, Department of Dermatology, Venerology at AIIMS, New Delhi. He has more than 250 publications, and his main interests rise in vitiligo, dermatosurgery, artificial intelligence, and STI. Over to the presentation.
Hello all. I thank organizers of Pigmenticon 2022 for inviting me for this excellent workshop session. And in next 15 minutes, I will be speaking on introduction and overview of vitiligo surgery. So before I come to the main topic, here is the brief history about vitiligo surgery. Hexthorson first experimentally used exchange split graft between vitiligo and normally pigmented skin, but the first use in clinical disease for patients was done by Dr. Behel in 1964. Falabella introduced not only suction blister grafting, also mini grafting and in vitro cultured melanocytes in 1989. Gauthier first introduced non-cultured epidermal cell suspension, which was improved further by Olson and Jovelin in 1998. Dr. Na from Korea first introduced the hair follicle micrograft, and we at AIIMS first introduced the extracted hair follicle cell suspension transplantation in 2011. So first question is, when should we consider vitiligo surgery? So when the disease is immunologically stable, first and foremost, and when the melanocyte reservoir is lost or inherently missing, like areas where there are no hair follicle, because hair follicle provide the reservoir to melanocytes. When the medical treatment is no more effective or minimally effective, like in presence of leukotrichia or acral vitiligo where there is no melanocyte reservoir. When only residual patches are therapeutic target of surgery, then we can do it. Large extensive areas cannot be treated surgically. When patients' expectations are unrealistic, we should decline. We should always counsel to the patient that what we are going to achieve, it's not a cure, it is cosmetic cover, and disease may recur at other sites as well as at the transplanted site. So apart from history of inactivity and absence of Koebner phenomena for 1 year, we also should look at the clinical features of stability. So hypomelanotic lesions with poorly defined borders are not a candidate for surgery. Amelanotic lesions with sharply defined borders are the candidates for surgery. So those who have poorly defined borders, they continue to progress. Perifollicular depigmentation is another poor prognostic sign in respect to stability. So another thing is pseudocoats. What we observe is that invert pseudocoats of pigmentation or hyperpigmentation is a favorable sign. Outward pseudocoats of hypopigmentation and depigmentation are adverse sign for transplantation in surgery. So this is, you can see that hyperpigmentation is approaching the depigmented area. It's a good sign. Here you can see that border is ill-defined and there are pseudocoats of hypopigmentation encroaching the normally pigmented skin all around. It's a poor prognostic sign. So eventually you can see that the lesion has become well-defined but has progressed around the nipple, and still the new area is not so well defined. So still the patient is not a favorable patient for transplantation. So this is the story of two female patients who had a similar lesion, segmental vitiligo on the face, and one had poorly defined lesion and the other had well-defined lesion. And you can see the difference in the transplantation outcome. This is a brief summary of what are the techniques available. We have tissue grafts, we have cellular grafts, and we have non-grafting techniques like therapeutic wounding, local excision, etc. So among the tissue graft, there are full thickness punch grafts, split thickness grafts, suction blister graft, hair follicle grafts. In cellular grafts, there are cultured grafts and there are non-cultured grafts. But in this recently published meta-analysis in JAMA Dermatology, they reached to a conclusion that tissue grafting had a higher success rate as compared to cellular grafting. This is obviously an erroneous conclusion because, as we pointed out in our comment on the article in the same journal, that they did not take into consideration various factors which could have influenced the vitiligo surgery outcome in different grafting techniques. For example, they did not take they did not do a multivariate analysis of segmental versus non-segmental vitiligo in each category, disease duration, stability duration, body surface area involved, size of the treated patch, and concurrent medical therapies. All these factors can influence the outcome of surgery. So when we compare different techniques, we should always take these factors into consideration and do a multivariate analysis. So what they found, otherwise the article was very good. What they found is that as the mean age increases, the transplantation success decreases. As the proportion of segmental vitiligo increases, the transplantation success increases. As the proportion of acral and joint area increases, the transplantation success decreases. So these are some general principles of transplantation one should keep in mind when we are doing procedures. So here, past, present, and future. Earlier, we used to achieve some kind of pigmentation just to cover the white areas. Now we plan for aesthetic repigmentation with perfect color match. Earlier, we used to have aim at hidden donor site scarring. Now we don't want any kind of donor scarring. Short-term repigmentation was the goal. Now the long-term or even permanent repigmentation facilitated by maintenance therapy is the goal. Earlier, we used to wait for stability for 1 year before transplantation. Now we induce stability in progressive disease and do transplantation. Targeted biological treatments to induce remission in vitiligo with minimum adverse effect have given us an opportunity to induce stability with least side effects and do the transplantation. So coming to past, present, and future, another aspect is that the unit of the graft is getting smaller and thinner. So we have dermal component in harvested recipient tissue, which is unnecessary. Not only unnecessary, at times it is detrimental to the final outcome. I will tell you how. So the basic principle is the transplantation unit is getting smaller and smaller. From tissue grafting, we are moving to micrografts and to cellular grafts. From punch grafts, we are moving to mini punch grafts and micrografts. For example, long ago, we did an experiment we transplanted trypsinized epidermal flax, which resulted in a very wide perigraft transmission of repigmentation and melanocytes transfer as compared to punch graft, because punch grafts contain dermis and epidermal flax do not contain dermis. So this is the principle. Dermis is detrimental to the final outcome because we just want epidermal melanocytes to be transplanted. So you can see that how these tiny flecks resulted in complete repigmentation. Another aspect is thin split thickness graft has given the way to ultra thin or suction blister or smesh graft, punch graft to mini punch graft and micrograft. The Jodhpur technique, which is very tiny epidermal flak transplantation using motorized dermabrader, is again miniaturization of the transplanted graft unit. Tissue grafts have given way to the cellular grafts. So mini punch graft, large punch used, cobblestoning not acceptable. And recently, earlier this month, we saw this patient treated with large punch graft and in an active disease. So grafts lost pigment and what is left behind was cobblestoning. This is not acceptable. So this patient we treated with 1.2 mm grafts. So grafts are not visible, but pigmentation is. So Dr. Jung introduced this technique of motorized 0.8 mm micro punch graft obtained with hair follicle extraction punches. They obtained epidermis from tiny epidermis punch 0.8 mm and transplanted, which resulted in a very good repigmentation. The smaller the graft unit, better is the aesthetic outcome. And they further reduced the size to 0.5 mm. They use motorized punch. And here the beauty is that you need not to bother epidermal side up or dermal side up. Just do the transplantation, just put the graft without bothering about the upside down or correctly placed. So another patient, thin split thickness graft, thick grafts used here. So good repigmentation, but very poor aesthetic outcome. So we use here motorized ultra thin graft. So there is less perceptible graft, but still graft is okay, not very excellent. Unlike in suction blister graft, where we get no texture abnormalities because we are just transplanting pure epidermis. Then somebody did an again thick split thickness graft, resulted in pigmentation, but not very aesthetic repigmentation. In this, we did non-cultured epidermal cell suspension, very good repigmentation, some miscolor match, but no texture abnormality. Another issue is leukotrichia. Now, this leukotrichia is a very challenging problem. Some patients show good repigmentation of leukotrichia after transplantation, but this is an exception, not a rule. And we systematically studied what proportion of patients have repigmentation of leukotrichia after transplantation. And what we found is, while there is very good repigmentation of epidermis after hair follicle cell suspension transplantation and epidermal cell suspension transplantation, there is very poor repigmentation of leukotrichia. So these blue bars showing leukotrichia repigmentation with both the techniques. So you can see only a small proportion of hair get repigmented is against very good repigmentation with both the techniques in epidermis. So leukotrichia remains a challenge. So sometimes at cosmetically challenging sites, we have to do FUE transplantation to treat leukotrichia. So we can do NCES for epidermal repigmentation and FUE for leukotrichia repigmentation. What is the beauty is that we can take the graft from contralateral eyebrow so that they don't grow long and they better match with the surrounding hair. So another thing is cultured melanocyte transplantation. This is needed when there is a large area of depigmentation. Then you take a small sample and send it to the laboratory for expansion in the laboratory and do the transplantation, but it needs a lot of laboratory setup. Another aspect is sometimes the repigmentation with cell suspension or other tissue grafting techniques is very good, but it doesn't last. Like in this patient, after a year, he lost the achieved repigmentation. And this young lady also had good repigmentation in the initial phase, but when she came a year later, she lost some of the repigmentation which she had achieved. So this is the problem. So what we have to do, we have to achieve stability of surgically achieved repigmentation. And long-term studies have shown that about a quarter of the patient with non-segmental vitiligo will lose their pigment achieved by surgical transplantation. So what we can do, the answer is simple. We have to do give some maintenance therapy like tacrolimus. So tacrolimus prevents the loss of surgically achieved repigmentation in a significant majority of the patients. Another is peri-procedure cyclosporin. We can start cyclosporin a few weeks before surgery and continue for a few months post-surgery to achieve better repigmentation. Biologics is the future. So the importance of biologics is that we should understand that the success of surgery depends on effective biologic or other drugs which can achieve stability through the drugs, and then only we are able to do transplantation. And some of these issues and other issues have been discussed in our book, International Book of Vitiligo, which is published by Wiley. You can go through it at some time. And I must end with this ancient folk saying, inscribed in the statue of Edward Livingstone: to cure sometimes, to relieve often, and to comfort always. This is how we need to treat vitiligo.
Thank you, sir, for such an excellent overview of the workshop. It was indeed a great way to kickstart this workshop. For our next talk on tissue grafting, I invite our esteemed speaker, Dr. Deepak Mohana, who is the director of Mohana Skin, Hair and Hair Transplant Surgery. He has given various trainings and workshops in the field of vitiligo surgery, has been felicitated for his social work in dermatology by various bodies, among other honors. Over to you, Deepak, sir.
Hello, everyone. I thank the entire team of Pigmentricon for inviting me for the today's vitiligo surgery workshop session. And I would be discussing the tissue grafting techniques in vitiligo. The various tissue grafting techniques in vitiligo are the mini punch grafting, which can be done by manual method or the motorized one, thin split thickness grafting, suction blister grafting, hair follicle grafting, and the mesh grafts. So the advantages of mini punch grafting are it's easier to perform. In fact, it's the most basic vitiligo surgery. It has a less learning curve and no special equipment is needed. But the disadvantages of mini punch grafting are it can give rise to cobblestone appearance. It can give rise to scarring at donor site. More time is taken for the pigmentation to occur. And the mini punch grafting current status for indications is like for acral vitiligo, angle of lips, post-burn, scar depigmented area. So let's see the video of the manual technique of mini punch grafting. So I'll be demonstrating the mini punch grafting on the lower legs. The first step is to infiltrate the area with the help of xylocaine 2%. I'm using the 26 1.5 inches needle for infiltrating the area. The next step is to create the punches at the recipient side. I'm using 1 mm sharp punches for creating the punches. Emphasis can be given to create the holes at the border of the vitiliginous area because it's the most crucial site at which sometimes the peripigmentation halo occurs. Even after the results occur, there is a halo of depigmented area around the lesions. So special emphasis should be given to that area. As you can see, if a proper depth up to the deep dermis is maintained, the grafts just pop up. And after that, half of the grafts come out easily, and sometimes they can be just cut with the help of scissors, with the help of pointed forceps and the scissor. The next step is to infiltrate the donor area with the help of xylocaine 2%. The point I would like to focus upon is no adrenaline is being used in the anesthesia, both at the recipient side and the donor side. Then we use the same size of punch for both the recipient and the donor area. Special emphasis can be given on the movement of the hand in the creating the punches. That is the rotatory clockwise and anti-clockwise movement. And I'm showing the punches on the hand along with the graft holding solutions. Proper differentiation of epidermal surface and the dermal surface is important. The epidermal surface has a light brown to dark brown pigmentation, while the dermal surface have a whitish to cremation color. Also, at this step, it is important to hydrate the grafts, because this is one of the most crucial steps where sometimes desiccation of the grafts occur, which can reduce the viability of the grafts. So only 1 to 4 grafts should be taken at the hand at one point of time, depending on the speed of graft placement. And after that, the grafts are being placed at the recipient sites, which are already punched. After the placement of the graft, it is set down with the help of pointed forceps, and the graft should snugly fit in the recipient sites created. The dressing is done with the help of Sofratule and Cuticide classic dressing, and post-operative antibiotics and analgesics are advised for 7 days. Next, I will demonstrate the motorized mini punch grafting. The various advantages of this process are: large areas of generalized stable vitiligo can be covered in less time, least chances of cobblestone, and then it also avoids the operator's stress and also avoids pain in the operator's thumb, which is otherwise experienced with the manual mini punch grafting. So let's see the video of motorized mini punch grafting. Punch size which I have used in this motorized mini punch grafting is 0.9 mm. So that's the reason the cobblestoning, which can happen with manual punch grafting, even by using 1 mm punch or 1.2 mm punch, it is reduced significantly by using smaller size punches. So in this surgery, I am using the 0.9 mm punch. However, 1 mm can also be used. The rest is the speed of the motor. I have set motor speed at around 800 to 1200 RPM and just piercing the skin to the level of mid dermis to deep dermis. At the most of the sites, the grafts which are created with they are just displaced from the site, and they need not to be removed like you have to do in manual punch grafting, because the punch size is very small. But the problem with this surgery is the bleeding is comparatively more as compared to the manual punch grafting, and also the learning curve is more, because to handle the motor, to handle the speed at which the motor is rotating, the sharp movements which are needed, and also to have the graft punch create at the border of the vitiligous area is important. But once the hand is set, and after the proper training, you can attain good speeds by which you can do 500 to 600 grafts in less than an hour. So we term as giga sessions in the vitiligo surgery, like 500 to 600 grafts, because usually for the manual punch grafting, only 100 to 150 grafts can be done. The next is the punching at the donor side. As you can appreciate, very less bleeding is there, but usually in the motorized one, more bleeding occurs as compared to the manual one. the less bleeding is happening at the donor side because I'm just touching the skin surface and reaching only till the upper dermis to mid dermis. So as you can see, with proper training and proper expertise, a good speed can be maintained, and a full punching of the donor area will require less than 5 minutes. So in the less than 5 minutes, you can harvest around 400 to 500 grafts from the, you can punch the 400 to 500 grafts in the donor area. Because as in hair transplantation, we also have to reduce the time of the implantation and the placement of the grafts. So this reduces the overall time of the surgery, which increases the viability chances of the punches which are harvested. So the whole area has been punched with the help of motor, and the same speed I have maintained 800 to 1200 RPM. Now we are removing the remaining punches which are there in the recipient area, and now we will cut down the punches from the donor area. So these grafts are being cut from the donor area and then transferred onto the person who is placing the grafts on the recipient area. So by this method, when you are directly placing the grafts into the recipient area, you can also reduce the time, so reduce the surgery time, and also you can increase the viability because you have reduced the chances of their killing and increase the survivability by reducing the surgery time. One by one, the grafts are being harvested from the donor area. And another important point is that during the placement of the grafts, you have to just place it on the recipient area and just snugly fit into the hole which are created and set it with the help of pointed forceps. Proper care should be taken to hydrate the grafts at this step. As compared to the manual method, in the motorized punch grafting, as the grafts are very small, sometimes it becomes very difficult to differentiate the epidermal surface from the dermal one. So this is the crucial step for implantation, and it should be taken properly care of. So this is the final view. Next is the split thickness grafting. In this technique, thin split thickness skin grafts are harvested from the pigmented donor area and transplanted at the recipient sites as continuous sheets of tissue grafts. After infiltrating the area with the help of xylocaine 2%, with the help of handle, the grafts are being secured, and as you can see, very ultra thin graft has been harvested. The grafts can also be harvested with the help of silver handle for the large vitiliginous areas. Next is the suction blister grafting. Suction blister grafting is a technique where the pigmented epidermis is harvested and from the donor side by using suction to raise a blister, which is then transferred to the vitiliginous areas. It can be done by syringes or suction pumps. Syringes of sizes 10 ml and 20 ml are applied to the Vaseline coated donor site. Approximately 20 ml to 30 ml of air is aspirated using a 50 ml syringe and a 3-way cannula. It usually takes 2 to 3 hours for the development of blisters. Current indication is lips. Like mostly we do the suction blister grafting for the lips. So these are the formation of blisters. Then after deroofing, the deroofed blisters are placed on the dermabraded sites. And then next one is the hair follicle grafting. So as repigmentation of vitiligo is closely related to hair follicles, hence replenishing melanocytes in vitiliginous patches utilizing undifferentiated stem cells of the hair follicles using FUE is a possible treatment option. Its advantage is this reservoir of undifferentiated stem cells is much more resistant to autoimmune attack of vitiligo. Let's see the video demonstration of hair follicle grafting by FUE. This is the first step after proper asepsis and betadine preparation of the recipient area. I have given the anesthesia with the help of xylocaine 2% vial. There will be difference in this surgery, like we will use the adrenaline at the donor side, but you won't be using the adrenaline at the recipient side. So in this hair follicle grafting video, I will be showing two patients simultaneously. The first has the vitiligo over the frontal scalp, and the other one is a male patient who has the vitiliginous area on the legs. These are the recipient sites which are being created at the vitiliginous area. The advantage of pre-made slits is that we can count the slits already, so we can harvest the same number of grafts as per the slits created. The slits are being created with the help of 18 number needle, and the depth is just below the deep dermis. As you can appreciate, the angle inclination of slit creation is very low, around 20 to 25 degrees. Then is the harvesting of the grafts. First, we are anesthetizing the area with the help of xylocaine 2%, and adrenaline is used in a lower concentrations in the donor area. So this is a punch we will be using for harvesting the grafts. Motor speed is less as compared to the motorized punch grafting, and the motor speed is around 300 to 400 RPM just to cut down the skin. We feel a giveaway, so that this is the proper depth at which the nick is being made in the skin, and the graft just pops out if a proper punching of skin is done with the help of motor. There are minute bleeding points, but some patients bleed profusely, so that's why adrenaline should be used in the lower concentration at the donor area. Transaction rate should be as minimum as possible to harvest the grafts for the proper results. So this is the side view. So you can appreciate the punch is just going inside the skin. The size of the punch we are using for this grafting is 0.9 mm length and 4 mm bore size. We are using sharp serrated punch for the harvesting of grafts. And also you can appreciate the grafts just pop out from the skin, and after that they are being plucked out with the help of curved pointed forceps. These are the grafts which are being extracted from the donor area. In this surgery also, with proper training and expertise and experience, one can harvest around 500 to 800 grafts per hour. Like in hair transplants, we do around 900 to 1200 grafts per hour. Proper care should be taken to hydrate the grafts at this step. So as you can appreciate, these are the single follicle, double follicle, and triple follicle hair grafts, and these are being transferred to the petri dish containing a graft holding solution. The graft holding solution can be normal saline, and also it can be Ringer's lactate. Various recent graft holding solutions had also come up, like ATP liposomal solutions, but usually we avoid using them for the vitiligo surgery because usually the time taken for vitiligo surgery is less as compared to the hair transplants. The next step is the implantation of the grafts. We do the implantation by the no root test technique, in which with the help of implanters, the graft is being loaded into the implanter, and then from the non-root end, it is being loaded, and after that, as you can see, from the non-root end, the graft is picked up, loaded into the implanter, and then they are being implanted into the vitiliginous area. So as the slits have already been created, we have already prefixed the angle at which these hairs will grow. But as we have harvested from the neck area, from the nape of the neck, from the occipital area, so these hair graft will be thicker in caliber and will be longer. So the patient has to trim these hairs. And for the frontal scalp, this is that we are placing the grafts from which we have already extracted the lipotrachea hairs. So we have harvested the lipotrachea hairs, and the holes in which we have which are created, we are directly placing the grafts onto the recipient sites created. These are the final look of the placement of the grafts. The blue tinge is because of the methylene blue ink, which has been used after the slit creation. For the females, this is the window created at the back of the head for harvesting of the grafts. Dressing is done, and post-operative antibiotics and analgesics are advised for 5 to 7 days. The dressing at the donor area is for around 24 hours. No dressing is being done for the recipient area. And this is the final look of the recipient area of the female, in which we have extracted the leukotrachea hairs. Thank you very much for the patient hearing. This is the photograph from the PigmentriCon Indore a few years back. And I must say that in very few years, we can have the automated punch grafting technique for the vitiligo, but the money cost involved and the expertise will definitely a limiting issue. Thank you.
Thank you, Dr. Mohana. It was a very practical session with a lot of tips and pearls, thanks to which I'm sure our attendees are now confident about the first step in vitiligo surgery. For our next talk on non-culture epidermal cell suspension, I now call upon our speaker, Dr. Madhulika Mhatre, who's the Chief Director and Dermatologist at Skin Saga Clinic in Mumbai. She's also the recipient of various international scholarships and awards, including the Young Dermatologist Award, and she's authored various chapters, articles, and delivered talks in national and international conferences. Over to you, Dr. Madhulika.
Hello, everybody. I'm Dr. Madhulika Mhatre, consultant dermatologist from Mumbai. So today, the topic that has been allotted to me is non-cultured epidermal suspension or melanocyte keratinocyte transplantation. Now, most of us do know the theory behind the procedure. So what we are going to focus is the practical aspects only. Now, vitiligo and non-vitiligo leukodermas form an important spectrum of hypopigmented disorders, where the stark white patches that you see expose the patients to immense cosmetic embarrassment as well as a social stigma. And however, many of them with absolute stability do not respond well to conventional conservative therapies, and that is where the surgical interventions come into play. Now, the indications mainly that we are talking about today, as far as this procedure goes, is vitiligo. However, the same procedure can be used in the treatment of, say, hello-nevus, nevus depigmentosus in some cases, post-burn leukoderma, post-laser leukoderma, chemical leukoderma, post-DLA depigmentation if the case is burnt out, and in piebaldism as well. Now, what is the aim of surgical treatment? We want to replace the melanocytes. We want to obtain complete repigmentation as far as possible, achieve a good color match, and avoid disfiguring the recipient as well as the donor area. Now, what are the advantages of non-cultured epidermal suspension? Now, with this procedure, any anatomical site can be treated. The donor-recipient ratio that is required, that is the size of the graft, can be 1/10 the area to be treated. So this is a very big advantage here. There is no or minimal scarring if the procedure is done well in skilled hands, and the color matching achieved is next to perfect. So these are the advantages. Moreover, it's a daycare procedure. It takes anywhere between an hour and a half to 2 hours at the maximum. Patient can be discharged immediately. There is no hospitalization or admission required. Absolute immobilization may not be required, because once the solution is placed in place and a good dressing is given, the patient can move about. Dressing removal can be done between 3 to 7 days, depending on the area which is being treated. The maximum area treated at one sitting can be around 300 square centimeters. And if there is partial repigmentation, say post-procedure, the same area can be retreated without any chance of disfiguring. Now, compared to the conventional methods, now if we place them side by side, your conventional surgical options, non-cultured epidermal suspension and cultured epidermal suspension. Yes, the cultured scores above the other two in all aspects, as far as the technique simplicity is concerned, the training required, the cost incurred. However, non-cultured does find a safe space in between the two, where it is neither too complicated. Training can be easily obtained in the procedure. The cost is not too expensive either. We've learned to modify and simplify the procedure as well as the materials that are needed, so that the cost for setting up a vitiligo surgery center or a unit where NCES is performed comes to the minimum. Phototherapy may or may not be required post-procedure. The chances of adverse reactions compared to your conventional methods as far as scarring is concerned or the donor area disfigurement is concerned is very, very minimal, and results are more than satisfactory. Now, just a brief overlay. This is a diagram which shows the stepwise, the steps in the procedure of NCES. Our aim or a principle is to transfer the melanocytes from the donor area to the recipient area, where the multiplication of melanocytes will help repigment the white patch. Now we are going to take this step by step so that I can explain it to you better. First step is always going to be anesthesia. Now, again, depending on the age of the patient, the location of the patch, anesthesia in the form of local anesthesia, conscious sedation, or even general anesthesia when treating over-anxious patients or larger body surface areas can be used. Amongst the local anesthetic agents used, injectable without adrenaline is what we prefer. Topical EMLA is the other most common agent which is used. And in our practice, we are using a specially formulated topical cream which contains 23% lidocaine, which gives excellent surface anesthesia even after 30 minutes of application. However, if using the typical EMLA which is available in the market, it may require at least 1 hour of anesthesia before you start your procedure. Most of the steps, if doing for smaller areas, can be done totally and completely under topical anesthesia only, without the need for any injectable. However, if the patient is a little anxious, or when you're performing surgery for children, we may require to use conscious sedation. However, we may take help of an anesthetist to be present during the procedure. And if wanting to do a larger body surface area, a general anesthesia is preferred, and the procedure should be done in a hospital setting in case any adverse events do occur. Now, coming to the first step of the procedure, that is harvesting the graft from the donor area. Now, after the area is cleansed properly with betadine and spirit, a thin graft is to be taken, ideally from the anterior aspect, upper anterior aspect of the thigh, or the upper aspect of the buttocks can be used as well. Make sure the area is stretched properly so that the surface while taking the graft is almost flat and parallel to your moving blade. We do apply a petroleum jelly over the area to make sure the gliding of the blade on the skin is very, very smooth and swift. In our practice, yes, we do use a simple razor blade with an artery forceps. However, people who are comfortable using the dermatome are free to do so. However, using the dermatome does require a little bit of skill, so you can practice, say, on simple day-to-day vegetables to get your hand set to the moving of the blade over the flat area so that a thin graft can be obtained. Now, the thinness of the graft should be, you should be able to read the alphabets on the blade that is being used. So that is how you can gauge whether you've got a really good thin graft. Now I'm going to quickly show you the video. So with the help of an assistant, you can ask them to stretch the area for you so that it is completely flat on the skin, with smoothly gliding the blade over the donor area. See, as you can see, the alphabets on the razor blade are visible. That means we have got a nice thin graft. So once we get the graft is placed in trypsin solution in a Petri dish, and it is placed in an incubator at 37 degrees Celsius for around 20 to 30 minutes. Now we do prepare our own trypsin. However, trypsin is available as a commercial preparation, which you can purchase from certain companies. I will be sharing the details later with respect to the materials and how to obtain them. As far as an incubator is concerned, any lab grade incubator will also do. However, those are a little immovable and not really portable. What we use in our practice is a egg incubator. However, the temperature, there is no temperature guide or a temperature monitor over these incubators. So it does come with a mercury thermometer, which helps you know what temperature has been achieved. So we are looking at a 37 degrees Celsius temperature for 20 to 30 minutes here. So in the meanwhile, while your graft is getting incubated, the step 3 is dermabrasion of the recipient area. Now, dermabrasion can be done either with a motorized dermabrader, or if you're comfortable with a Manikshaw's manual dermabrader, that can be used as well. Of late, dermabrasion has also been attempted with CO2 lasers or fractional erbium yak lasers. So either of these modalities, whatever is available to you or comfortable with respect to your skill sets, can be utilized. Now, hold it like a pen. That is what we've always been taught. So you have good control over it, whereas your other fingers are supporting the instrument on the skin to make sure that you're not going too deep. It has to be very even dermabrasion. So since the phrase is rotating like a wheel, the movement of the hand has to be vertical over the patches. Another video here showing how the hand is supported, how the dermabrader is being supported by the finger of the other hand also, so that you're achieving a good dermabrasion without going too deep. Here the endpoint is going to be pinpoint bleeding on the surface. That means you're in the, you've managed to remove the epidermal layer and you're just at the junction. Now, this is how the area should look post dermabrasion. Even surface, the dermabraded surface with pinpoint vessels which are seen. Always try and mark the area with a pen before you start your dermabrasion, because once you start, at times the surrounding area does appear a little white and it may be really difficult to distinguish the patch from the normal skin, especially when you're treating fair-skinned individuals. After the dermabrasion is done, we move over to the next step, that is washing off the trypsin from the graft. Now, ideally, as per textbooks, you may see the mention of anti-trypsin solution. However, we found a workaround about it. We do not use the anti-trypsin. The graft can be washed, say, with DMEM medium or with simple Ringer's lactate as well. So after the 30 minutes of incubation is finished, the graft is taken out of the incubator. The extra trypsin which is in the petri dish is removed and the graft is washed at least 3 to 4 times with Ringer's lactate. If your trypsin solution was well made, if your incubation time was perfect, you can see, as in this video, the dermis simply separating off without any teasing or manipulation. You can see this white thing here is the dermis, which has nicely separated. I'm going to show you another video here of a larger graft. As you can see, this is the white dermis here as well. So this is the key, or this is an indicator of good incubation. The dermis comes off. Now, once the dermis is off and it has been washed with RL to get rid of complete trypsin, the graft is then teased to separate the melanocytes into the suspension. Right, as you can see, with the help of 2 forceps, the graft is held in place and teased gradually to separate the cells. So once the teasing is done, we do have our solution here, which contains the separated cells. This particular image shows DMEM being used as the medium to wash the trypsin and prepare the suspension. However, this can be just as easily done in a Ringer's lactate solution as well. Then it is made to centrifuge for 5 minutes at 2000 RPM. And at the end of centrifugation, what you will be able to see is this cell pellet here. Now, because the DMEM is so highly colored, you may not be able to have a good visual here. So I am going to show you the suspension, which can be seen here with the pellet at the end, which is this dark colored pellet, which are your melanocyte cells. Now, once that is done, the excess is removed, the excess of the solution, the top 2/3 is discarded, and a concentrated solution is obtained where the pellet is mixed into a little bit of amount, the lower 1/3 of the suspension that was prepared. So we resuspend the suspension in a tiny amount then. After that is done comes step 8, that is seeding of the cell suspension. We've already got our dermabraided area. Now all we need to do is put the suspension on the dermabraided area. We use a glass pipette to take in the solution, put them in 1 ml syringes from the top, and gradually with minimal pressure, the suspension is seeded or slowly applied over the dermabraided area. Now, after the suspension is applied, we do dressing in a 4-layer fashion, where first a collagen sheet is applied, followed which a paraffin gauze is placed on it, then a simple sterile gauze, followed by sealing with a micropore tape. At times, in certain mobile areas, we do use roller bandages or crepe bandages to hold the dressing in place. Now, these are a few results that I'm showing you. Another female where you can see the color matching with respect to the different colors in the areola can also be achieved. The genital areas can also be safely treated with this procedure. The palm of the hand. Now, though we say that acrofacial areas do respond poorly to any kind of surgical management, a few cases do form an exception. Now, this is a case of post-DLE depigmentation. Though our talk today is only about vitiligo, I'm going to share a few of our non-vitiligo leukoderma before-afters as well. Chemical leukoderma post-hair dye, again, excellently repigmented. In burn scarring, now this seems to be quite a common problem without a perfect solution because medical management does not work here. So NCES can be a good alternative in these cases. Again, some pictures of post-burn leukoderma, which can be repigmented with NCES. Post-laser depigmentation also managed with this procedure. Halo nevus, we all know, is commonly seen in association with vitiligo. And this is where NCES can also help pigment the peri-nevus halo. Now, however, in nevus depigmentosis, we found mixed results. Maybe NCES may not be the perfect solution for this case because probably the pathogenesis of nevus depigmentosis is not completely well understood. And the problem could be in the transfer of melanocytes or the dendrites of the melanocytes. So we've seen color, the area repigmenting pretty well. However, the color did not stay very long. So the patient relapsed. And we've come across a few articles which say that epidermal sheets probably could be better. This is a letter to the editor by none other than Dr. Somesh Gupta sir. So yes, while treating nevus depigmentosis, you should be keeping this in mind. Now, now that we've gone through the procedure, I hope everybody is feeling much more confident starting this in their practice now. And I'm going to briefly go through the steps again and the material used and where you can source it from. So the step 1, which was a shave biopsy from the donor area, as you all know, the only things you need here is spirit, betadine, shaving blade, lubricant jelly, and syringes, which can be sourced from any local pharmacy. The artery forceps, silver skin grafting knife, Boolean knife, or a Zimmer dermatome can be used as far as the graft taking is concerned, purchased from any surgical store. But what we find the most convenient and most cheap alternative here is the razor blade. These are a few local suppliers in the major metros at least. So I can share this with you after the presentation. Now, the second step, that is transfer of the graft to the trypsin. What is required here is forceps, petri dishes, and the trypsin ADTA solution. The forceps that we used were the Addison straight forceps, which most of us do have in our OT setups or even procedure room setups. Petri dishes, make sure they're autoclavable and can be easily available from any surgical company. Trypsin solution can be purchased by itself alone or as a part of certain kits which are available these days for melanocyte transplantation. These are a few companies which do sell trypsin, antitrypsin, DMEM, or kits as a whole as well. Depending on the method you want to follow, you can purchase these things. When it comes to incubation, I've already mentioned that you can use any lab grade incubator or something as simple as a good egg incubator. Dermabrasion of the recipient area, we need the burrs, which are your burr Ellis diamond phrases from Delasco or Derm India, pretty good. The handpiece is a straight handpiece from NSK or Marathon Motors, and the micro motor is again from Marathon. Dermabrasion of the recipient area, like I said, can be done with the help of lasers as well, or with a manual dermabrasion, that is your Manixhaus manual dermabrator. Then we come to step 5, which was cell separation. Here, what we need is either the DMEM medium or the Ringer's lactate solution to wash off the trypsin. And to transfer the solution to the centrifuge, we use the Tarson's tube, which can be available from any surgical store. So centrifuge, again, whichever centrifuge you do have, most of us do have it in our practice for PRP purposes, and the same centrifuge can be used. Seeding of the cell suspension only requires a 1 ml syringe. Dressing of the donor area, yes, we prefer to do it with Duoderm, which can be available either online or through your surgical supplier. And for the foliar dressing that we do for the recipient area, as we mentioned, the collagen that we used is New Skin F. The paraffin gauze is Gelonet, sterile gauze and micropore from 3M. And the roller bandage or crepe bandage can be available at any local pharmacy as well. So this is how the dressing looks when it is done in 4 layers. You can also use Tegaderm, which is a transparent dressing, especially for areas of the face, so that it gives a slightly better aesthetic appeal rather than putting a micropore, and it is more waterproof compared to micropore. So this could be a good alternative for all your other dressings as well. So I like to end by saying that a person who possesses courage and presence of mind, a hand free from perspiration, a tremorless grip of sharp and good instruments, and who carries his operations to the success and advantage of his patient, who has entrusted his life to the surgeon, is the definition of an ideal surgeon. So I would urge all of you to start doing this procedure in your practice. If you do have any queries or doubts regarding it, we are all here to help you. Thank you very, very much.
Thank you, Dr. Madhulika. I'm sure we'll all agree that this concept of telling people how to source the equipment is going to be the major factor in removing the inhibitions from various people who've yet not started non-culture epidermal cell suspension. Very helpful. Thank you so much. For our next talk on preparation of the recipient area, I call upon Dr. Sumit Gupta from Skinnovation Clinics, Delhi. He's a recipient of STAR 2015 Award for Vitiligo Research at World Congress Dermatology, Vancouver, and also multiple awards and gold medals for clinical research in vitiligo from the University of Delhi. He's a consultant at multiple hospitals. Over to you, Dr. Sumit Gupta, sir.
Good morning, everyone. I am Dr. Sumit Gupta. I would first of all like to thank the organizing team and the scientific committee of the PigmentriCon 2022, particularly Dr. Manish Gautam sir and Dr. Madhulika Mhatre, for inviting me to this wonderful conference to speak on a topic which is close to my heart, that is non-cultured epidermal cell suspension transplantation. And I would be talking about the recipient side preparation for this procedure. So let's start by sharing. Okay. So non-cultured epidermal suspension transfer is nowadays the procedure of choice, in my opinion, for most stable vitiligo. So before I start my presentation, I would like to pay my respects to my wonderful teachers who've taught me this procedure and made me learn and perform this procedure over the years, Dr. Sanjeev Mulekar sir and Professor Nanya Van Giel. So if you look at the histogram of the skin, the ideal depth of recipient site preparation is neither this nor this. It is somewhere in this zone. So we always say we should dermabrade or whatever way we are preparing our recipient site, we should go on until we find pinpoint bleeders. So that is basically the onset of papillary dermis. So this is the ideal depth of dermabrasion that we need to do for properly preparing the recipient site. So it is even if we are doing let's say split thickness grafting, so we can go a little deep, we can go up till the bottom line. But for non-cultured epidermal cell suspension, ideally we should stay until that pinkish zone that I've shown in this picture, because we want the healing to happen quickly so that the melanocytes are viable at the time of reepithelialization. So the key points for achieving a good recipient site is, as I said, the onset of the pinpoint bleeding. The surface should be uniform. The recipient bed should be vascular. It should not be coagulated, or as we would see in further slides. The dermabrasion should be at least 1 mm beyond the edge of the depigmented patch, so that we do not get halos when the repigmentation happens. And the most important aspect to achieve all of the above is the correct tool that we can use to achieve this. So no tool is perfect. A tool is only as effective as the one who wields it and comfortably wields it. So there are a number of ways whereby this recipient site preparation can be done. First and foremost is the dermabrasion. It can be achieved by manual dermabraders or the Manex-Shaw dermabraders, or it can be achieved by microneedling. Although this is not ideal, but there have been few research papers where they have compared microneedling as a recipient site preparation. Then sandpaper, particularly the fine-grained sandpaper. Then motorized mechanical dermabrader, which is the most commonly used method of dermabrading for vitiligo, and also my personal favorite. Then there is this recent publication by Dr. Somesh Gupta sir, where he has described chemically assisted gauze dermabrasion, where they have applied salicylic and lactic acid solution, the kind of solution that is used for treating warts, on the recipient sites for about 1 to 2 days, and on before the day of the surgery. And during the day of the surgery, they've just used wet gauze to sort of easily dermabrade it. It's very interesting, and I will have to try it. I've not tried it myself. Then there is energy-based epidermal ablation. We can use radio frequency cautery. I'll show you how to do that. And then there are ablative lasers like carbon dioxide laser and erbium yak laser, the kind of lasers whose principal chromatophore is water. Then there can be ways to achieve dermoepidermal detachment by suction, the same way a suction blister is produced. So there has been some research papers where the blister has been created at the recipient site through suction, and in that blister, the suspension, the melanocyte suspension, has been injected. Then liquid nitrogen can also be used, and there have been some users of PUVA induced blisters, where they apply psoralen solution on the white patches, and then they expose to ultraviolet A, and there is a blister that happens, and you can inject the solution in that blister. So these are the conventional manual Manex-Shaw dermabraders that have been used for vitiligo surgeries. I find them slightly crude and difficult to use, particularly in areas which are contoured and slightly fragile. Then there is this sandpaper, which a lot of people use. I have also used them. There have been innovative ways to use them more ergonomically, like rolling it on your finger and also attaching it to a spatula and using it as a normal dermabrader. But the tool of choice, according to me, is the motorized dermabrader machine, which is essentially the dental motor, where we can use these types of diamond phrased burrs of different shapes and sizes according to our preference and according to the site we are going to dermabrade. So the ideal depth of dermabrasion, which I talked about, pictorially can be appreciated in this photograph, where there is no frank bleeding, but we can see the epidermis is denuded. We've reached the superficial dermis. So this is the ideal depth, according to me, for non-cultured epidermal cell suspension, and this also heals pretty fast. And the motorized dermabrader has a handpiece and also has a unit, which is the parent unit, and it is attached to the handpiece through a coiled wire. So this handpiece can be held in different ways. It can be held in a hammer grip, like shown in this photograph. So when one is using this hammer grip, the ideal kind of burrs that should be used are longer burrs, basically to use the sides of the cylindrical burr to as a dermabrating surface. And it is ideal for surfaces which are flatter and which do not have too much of a contour, and also slightly hyperkeratinized skin, particularly if the patient has been taking a lot of phototherapy. Those kind of sites are ideal for this kind of grip and this kind of burr. And the kind of motion that is used for this grip is forward and backwards, perpendicular to the direction of the rotation. Let me show you an example. So this is the dermabrasion of a patch on the acral region, where as you can see, I'm moving it forward and backward, perpendicular to the direction of the rotation. And this way, when you're gripping like a hammer, you can press it against slightly with a slight pressure, so that you can dermabrate slightly thicker hyperkeratinized surface. You can see the kind of skin that is coming out. It is coming out in sheets, and you can just help your way along by rubbing it with a gauze or just removing it. So that way you achieve a perfect uniform dermabrasion. The other way, which is more commonly used for surfaces which are slightly contoured and slightly delicate, is to hold it in a pen-like grip. And the kind of burr that is suitable for this kind of grip is rounded on the top. We can use different types of burrs. As you can see, there is a ball-shaped burr, there is a U-shaped burr, and also there is a drop-shaped burr. That can also be used for a very small delicate surface, or the borders or the skip areas that are left behind. The kind of motion that is used for this kind of grip is small circular motion, as we can see in this video. So this is a video of lip. Notice how I'm holding this with my other hand, and the best way to avoid any sort of blood going into the mouth is to apply some gauze piece in the lower vestibule between the lip and the gums, and from the other hand, just work it around with small to and fro strokes, circular strokes, until we achieve the desired endpoint. More of some other difficult areas like the umbilicus. You can again see me doing those small circular motions, so that I achieve good precision and good control. Also notice my assistant stretching the skin nicely, so that there is no folds, and the kind of dermabrasion that we achieve is uniform. It's also important to for your assistant to again and again dabbing the surface with saline soaked gauze, so that all the debris is removed and the dermabrasion can be conducted smoothly. So as I go along this, you can see the kind of frank bleeding that happens in the beginning, but once we cover it with saline soaked gauze, the bleeding stops, and then by the time the suspension is prepared, it's completely stopped. So the suspension stays there and it's not overflown by the bleeding. You can notice me changing the burr for a slightly smaller area that has been left. This kind of burr gives a better control for a smaller strip of an area of a smaller skip area, which can be easily dermabrated. Another difficult area is the areola. I prefer using this kind of burr for the areola because I don't want to sort of even by mistake uh, abrade onto the nipple if we don't want to abrade it, because it can sort of get detached from these areola if we are slightly overzealous and if our burr is slightly uh, broader. Also, use the lowest speed present on the motorized dermabrader to dermabrade this kind of area. It's better to go slow and steady rather than be out of control if you be too speedy. Again, to and fro motions. Also notice the kind of stretch that my assistant is applying. It's that stretch is very important. You can also use the belly of this burr in case there are certain areas which require a little more dermabrasion, and that's how we do it. Now the eyelid, it's the most challenging area among so many areas that we perform this surgery on. It's very important that your assistant is very alert while we are dermabrading this area. She should fix the eyelashes down here with the help of a gauze and should not create any sudden movement. The kind of alertness that you would like to uh, exhibit in this procedure, your assistant should also be similarly alert. No sudden movements. And again, the kind of dermabrasion is slow and gentle with small circular movements without applying too much pressure on the eyelid. So after maybe about one pass of this, we can just manually use the burr to dermabrate certain skip areas that have been there, that might have been left, so that we achieve a uniform dermabrasion. So this is the kind of endpoint that we achieve in case of eyelid. Now, using radio frequency cautery device for recipient side preparation, we need to use the ball probe. We need to use the lowest setting that's available on our device, and we need to move very fast while we are doing it. The surface should always be wet and always be made wet again and again using saline soap gauze. You can notice how this superficial layer of epidermis is coming out as we are going around it. So when we're doing it, our assistant will mop it to remove the debris, and then we can go about doing it. It's important to move very fast. If we are not moving very fast, we tend to create zones of coagulation, which still happens sometimes, as it happened in this particular patch as well. But by moving real fast, using low energy, completely soaking your patch in saline, making it wet, prevents this kind of coagulation. We want the bed to be completely vascular. So this is the end result of using radio frequency cautery as a mode of recipient site preparation. You can see there are two zones of coagulation that were caused in this particular patch using this. That's why it's not my favorite tool to achieve recipient site preparation. Now using ablative lasers. So this is the carbon dioxide ablative laser here. I'm using it in the surgical mode. I'm using this kind of handpiece because this is the one which we could sort of sanitize and sterilize for surgery. The advantage of CO2 laser is that it is available in a continuous wave where we can just apply it all over the patch. Again, use the minimum possible power for this particular indication. And once you are through with one pass, again and again, wipe that area until you achieve uniform dermabrasion. The disadvantage of using CO2 laser is, again, you achieve these kind of charred spots, which are sort of, again, zones of coagulation that have been caused by the laser, which are not that vascular and will probably not take up that much of suspension. But the advantage of this particular laser is that it's very fast. Compared to carbon dioxide laser, The other ablative wavelength, which is the erbium YAG wavelength, which is 2940 nanometers, has a better absorption of water. This is the absorption spectrum of different chromatophores present inside our skin. You can see the peak of water, that's the blue curve, is at around 3000, which is 294, which is close to 2940 nanometers, which is the wavelength of erbium YAG. Because of this high absorption in water, the coagulation or the collateral damage that occurs into the surrounding skin is much less with erbium YAG compared to carbon dioxide, which is around 10,000 nanometers in its wavelength. So this is erbium YAG laser. The disadvantage of erbium YAG laser is that it's not available in a continuous waveform. It is available only in a pulsed waveform, and it's kind of a slow process. We need to do multiple passes again and again, depending on the thickness of the skin thickness of the epidermis in that zone. And actually, my tryst with this procedure started with this study which I did as my PG dissertation, where I compared motorized manual dermabrasion with erbium YAG laser dermabrasion and compare both of these modes to create recipient site in terms of outcome. I found the outcome in terms of repigmentation was about the same in both the groups. It was a randomized control trial. And again, as I said, the downside was that the number of passes that was required for erbium YAG were too many, and it used to take so much of time. The advantage obviously is that it's a more predictable process. It has a slow learning curve. You can just use the fluence and just do multiple passes, whereas the motorized dermabrader has a slightly longer learning curve, although it can be used at multiple sites easily, even the so-called difficult sites. I believe the motorized mechanical dermabrader is the procedure of choice for me. So at the end, I would like to say that anything you can do needs to be done. So pick up the tool of your choice and get started. It's important to get started, whatever tool you prefer. I prefer motorized mechanical dermabrader, but it may be different for different people. But important thing is to get started. Thank you.
Thank you, Dr. Sumit, for such an informative talk and very practical points. Moving to the next talk, which is the newer innovations in vitiligo surgery by Dr. K.P. Ashik. Sir is a medical director and senior consultant at Amanza Skin Clinic, Kerala. He was editor-in-chief IADVL Textbook of Innovation in Dermatosurgery. Also, he has received a lot of orations at Dermacon, more than 85 publications in various national and international journals. And his clinical interest lies in clinical dermatology, vitiligo surgery, clinical photography, and information technology. Over to the presentation.
Good morning, everyone. At the outset, I would like to thank Team PigmentRecon Mumbai 2022 for this wonderful opportunity that you have given me to speak on innovations in vitiligo surgery. Vitiligo surgery is nothing new, and I think more and more people are taking it up. But there are some places where there is something not happening because that needs help. So I'm basically talking about those things which makes life easier for the vitiligo surgeon. I have no conflict of interest to declare, and whatever brand or whatsoever I discuss here has nothing to do with my lecture here. The ability to simplify means you eliminate the unnecessary things and the only necessary things are coming in the picture. So that is the simplest way you can call something innovative. Vitiligo surgery, the classical classification is here, and these are the things on which I am going to speak about: the cellular grafting, the punch grafting, suction blister, and the hair follicle grafts. So innovations of these things, the primary structure and the primary procedure is not going to be discussed here, which has already been covered by other lectures. Sponge grafting, this is in fact a paper published in 2006. I know it is not something to be called new, but I will still say it's innovative, using the 26 gauge, the needle hypodermic needle for lifting the mini graft and placing it in the donor area. Gorpade et al. Used tissue glue for keeping the punches in safe at the recipient area. So for the beginners, it's very useful. So you place the punch and put a little bit of tissue glue over it, and the results are very promising. This is a team from Bangalore, Chandrasekhar et al. From the Cutis Institute. What they did is they used a motorized punch. So the things becomes very easy because you can harvest a lot number and also prepare the recipient area very fast and do a lot of punches in a very less time. And the results have been very good. You can see how areola and the nipple has been done with this technique, and the results are pretty promising. Coming to the suction blister, you know that hijama cups are very much in vogue now. The hijama procedure, which the other systems and other people do. So it has a suction raising mechanism on its own, and bigger blisters can be raised with this one. So we don't need the suction syringe directly, and various sizes of cups are also available in the market. One of the problems that you face when we transfer the graft is, by mistake, again, in the beginning, we used to keep the graft upside down, and the results are going to be 0. So in such situations, a technique called writing number 4 over the suction blister was described by Korean researchers. And what we do is we write at the rate of. You take harvest and at the rate of and place at the rate of. And you are sure that the graft is in place correctly. A syringe cut to size, so you don't use a full syringe. This is by Mukhtar and others. So the advantage is the area of the syringe is reduced. So the time taken by the blister formation is very much less. And in between, for example, if you happen to be short of one blister once you're doing the procedure, you can use a quick blister raising with this method. So the time can be cut down drastically. This is another technique described by Somesh and others. You can see how this is a video which I shot recently, how you enter the blister from the side with a 26 gauge needle connected to a 10 cc syringe with normal saline loaded and inject normal saline. You can see how beautifully the blister raises and all the small blisters become one. And it is like one big balloon there, and the entire area is ready for harvesting. I do this procedure for every blister that I do, irrespective of whether they are formed or ill-formed, so that you harvest the maximum separated skin. This is tissue grafting. The cutting the graft, one of our first papers in the American Academy of Dermatology, where we place the graft on the butter paper, which is already there with you in the Gelonet, and the paper, other things come sandwiched. And you can place the graft onto the butter paper, transfer it carefully, putting a bit of saline and using two forceps, and cut it, and you can place the graft however you want, wherever you want, at ease, especially in places like this where maneuvering with a glass slide may not be very easy. Coming to the glass slide as such, you see the glass slide belongs to the pathologist and microbiologist originally. We do borrow it, and we have been using it for blister graft transfer. I find that when you cut the slide into half, the maneuverability and the ease becomes double. So that is how I've been using. So I don't use a full slide. I use only half slide for every blister transfer and handling. This is using of the cyanoacrylate glue, the usual, the commercially available super glue, which has been used for placing the graft intact after you keep it on the recipient area. We have been using this very often, and there has been no problem at all. One problem that the patient comes to you after surgery is they come and say that the graft is taken up well, sir, but the mismatch is very awkward, and somehow is there a way out? And they even ask you to remove this. Q-cyst NDX seems to be working now, but then there is another way which was described by Dr. Reddy and others from Bangalore. What they did is they did an incision like this, as shown in the second figure, and took it out and closed it, skin to skin, mucosa to mucosa at the edge, and the results have been promising. And that has been one big relief. At least somebody is there to help us out if you are stuck with an unpredictable mismatch of color, which is beyond us. Anybody, you can't say how it is going to be after the surgery. This people, what they did is they placed the graft and just left it like that, no dressing. But that looks a little scary. but sounds promising. But you need a cooperative patient who is really ready to take it up, and who is not willing for a dressing if that is the case. And you place the graft there and just leave it like that. So it dries up and keeps in place. And maybe 3 or 4 days should be enough for the melanocyte transfer to happen to the recipient area, and the results have been good. And they published it in the in dermatologic surgery. This is again from Korea. There are people who have done a lot of research in vitiligo. Cellular grafting, the conventional techniques and other things where the cellular grafting is what we are talking about, the melanocyte transplantation. Here, this is by Somesh and others from AIMS. What they did is they raised blisters. The concept is to use the body temperature and the body as an incubator, biological this thing. So what they did is they raised blisters, removed the fluid, put suspension into that, and that was used as an incubation. And then the suspension was removed, and then the other processes, and then it was used to place it on the recipient area, and the result was good. So you can actually bypass the incubation as such, incubator. This is axillary incubation. Again, simplifying it. No, the incubator is literally not needed, and the procedure is done with keeping it in the axilla, and the usual other techniques and separation, everything is done as per the usual protocols. This gentleman from Bombay, Agarwal Saurabh, he was finding it difficult to keep the bigger sized incubators in his in his area or whatsoever. So what happened is he made one himself with using very simple electricity and electronics, and it has a total temperature control. Everything is there, and this is in fact that is all you need for the resource poor alternative for incubation. Next is Sanjeev Gupta and others described. We use the Manaksha's manual dermabrader, take epidermal brushings, use those brushings, I mean those separated tissues for cellular process. So the entire process goes scar-free at the donor site and the recipient site. So that is one beauty of it, because at least even a small wound is not acceptable for the people now. So this sounds another promising technique. This is one Petri dish with 4 chambers. So instead of using multiple Petri dishes, what these people did was, this is actually published in British Journal of Dermatology from PGI, if I can remember. So the first compartment, they used it for incubation with trypsin EDTA. The next compartment was PBS, they washed it, and third compartment is also PBS. So repeatedly washing it after you take it out of the incubation. And in the fourth one, they did the tweezing. Another one technique was described by Go and others from Singapore. What they did is they used multiple PBS washing, nothing else was there, and suspension was separated. So these are all cutting down the cost of using trypsin inhibitor and other reagents, which are actually the costlier ones. Modifications of other modifications of MKTP is trypsin inhibitor can be avoided by washing the graft again in DMEM or other media, as I said, twice or thrice. Next is the results can be significantly improved by suspending the melanocytes in the patient's own autologous serum. You can use PRP. Suspending it in PRP can significantly greater enhance the pigmentation, repigmentation and patient satisfaction. Clohexidine gloss. So you can use Cuticel instead of the Gelonet, which has got a better result. Fluidiness can be reduced by using hyaluronic acid and suspending the fluid, the suspension in that, it becomes a viscous nature. Viscosity can be increased. And incubator may not be needed at all, because if you have a warm, and now like this climate here, we are boiling. So this is more than enough for you, but you may have to keep it for longer time. So the incubator may not be needed, because as these researchers said, Mulakar and others, one of the pioneers of vitiligo surgery, and they have described that you can actually use the room temperature for incubation. Dermabrasion and other related procedures. The technique is, I always use this headband whenever we do dermabrasion, because the hair coming in the field is a very difficult thing. One is the problem of dermabrasion as such. Another thing is, if it gets mangled with a micromotor, it is going to be really painful for the patient, and the entire thing becomes messy. So I use this headband, simple headband, which is available everywhere. So Sanjeev described this technique of using a usual hypodermic needle, doing left and crisscross drawing there, and that can be very well used to prepare the recipient area, and that is more than enough to keep suspension in place, and the cells will regenerate. Firoz described this technique of using a ballpoint pen, ballpoint tip of the RF, which can be used for just touching the surface and it burns off, and you can rub it off with a tissue, a wet gauze, and that can be another method for dermabrasion if you don't have a dermabrader ready with you. We tried this thing of using a sandpaper which was ETO sterilized, which can be wound around your finger, or you can hold it fixed onto a disposable sterile tongue depressor, or you can just hold it in your hand directly and dermabrade. The results have been very good, and it goes very well, very easy, especially when you are doing very sensitive areas like the eyelid. This is a Calazion clamp which can use as a lock, especially when you are a beginner, when you find that the lip is very slippery to operate, and in that situations you can lock it like this, but make sure that you dermabrade in this direction, left right direction, and not on the up down direction, because up down direction the chances of the lip getting again trapped in that and injuries are likely to happen. This is a technique where I use the eye shield, which is actually borrowed from the ophthalmologist. They don't use it anymore. You put lignocaine drops, the orocaine in the eye, and you also give topical anesthesia. Sometimes I give a few injections also there, local. And then what you do is you place the eye shield into the lid, and you get a very comfortable space to dermabrade. And that is very easy. You can see the results here, which has done on the extreme right, one of the patients which I did very early. This is a technique where Rasmi and others published, where they use TCA, 25% TCA. So you soak the surface with the TCA, and manually, the cells get degenerated, and you can manually dermabrade the surface to make it preparing the recipient area for vitiligo surgery. These are Chinese foot pumice stones kind of thing, which is usually for the podiatry practice. And that can be used, ETO sterilized and used as a dermabrader. So the advantage is you don't need electricity. It works on 12-volt power, which even a power bank of your mobile phone should be sufficient. This is where you prevent the suspension from falling away. You put a surgical glue and put a bit of tissue glue over it. You put a surgical suture. Next is a mesh, a simple plastic mesh, which can be used to keep the suspension intact so that it doesn't flow away. This is published by Somesh and Sanjeev and others. Next is a technique which is described by Sanjeev again, where the discarded tissue can be used as a biological dressing to place the recipient suspension. Kachawa and others described this Jodhpur technique of this thing for transplantation in vitiligo, where they did this, especially when it happens in the perilesional graft poor take. So what we can do is you can dermabrade this, mix the suspension, that skin with mupirocin ointment, and leave it like that, and the graft gets result is very good. Hair in vitiligo surgery, Kumareshan reported about hair transplantation, eyelid transplantation in residual leukotrichia, or even solitary leukotrichia of patients with vitiligo. These people transplanted eye follicles, and the results have been very good. They have done this in multiple places. The hair follicle as such, for outer root sheath can be used instead of the skin. You can harvest the graft. So if you are into hair transplantation, you will be very good in doing this process, and you may need to incubate it twice. That is one technique. That is one limitation, because unlike the other one, and you may need more follicles unlike the skin. The results have been very good, I think, and that has been very good. Needling has been described by Vijay Zawar and others, where you actually migrate melanocytes from the sites into the vitiliginous area. It is one of the things that has been done earlier under topical anesthesia, and it has been good repigmentation. There is a mapping method where you place a sheet, map, and do the surgery, so you can actually get a correct value, and 5-fluorouracil and efficacy of 5-fluorouracil with needling has been tried this way. 5-fluorouracil works as a very good vitiligo treatment option in surgical approach. This is again tacrolimus done with the same way. What they did is they used tacrolimus, and the results have been very good with needling. So the promising things are there in the pipeline, and whatever is coming now is extracellular fraction of adipose tissue as an innovative regenerative approach for vitiligo treatment. So there are so many things that coming up, and it is in fact really worth working and waiting for. I request all of you to keep innovating, keep thinking out of the box, try something new. We all fail, ultimately if you don't fail, you will never succeed. So that is what I would request you all. Get out of the tub and start now. Go back. Inventing. I hope the talk was useful for you, and I request each one of you to try out all these things and try out even out of newer things and come forward with publications, and let us all be useful. Thank you very much once again.
Thank you, sir, for such a wonderful talk. Great insights. Also, just mention to all the delegates, please write down your queries in the Q&A section so that we can address it to the speakers during panel discussion. Moving on to the next talk, it's case-based approach on difficult to treat areas by Dr. Mukesh Girdhar. Sir is a principal consultant at Max Super Specialty Hospital, New Delhi. He has over 17 publications and more than 200 presentations in various conferences. He's a recipient of Professor Sardari Lal Memorial Award for Outstanding Service in the Field of Dermatology, Times Healthcare Award in the category of Legend in Dermatology. His main area of interest being vitiligo and urticaria. Over to you, sir, for the presentation. You need to unmute.
Good morning, ladies and gentlemen. At the outset, I'd like to thank the organizers, especially Dr. Sunil Dogra, Dr. Rashmi, for giving me the opportunity to be here with you discussing the cases of vitiligo surgery, where I found some difficulties, tried to do things, learn things, and that's what I would like to share today. My job has been made very easy by the earlier speakers who have talked about every single aspect of NSCS surgeries, because I practice NSCS surgery, and all my cases I'll be discussing about have been done on the non-cultured melanocyte cell transplant only. Let me share my screen, please. So I hope my screen is visible.
Yes, sir, we can see your screen.
Right, great. Thank you so much. So as we talked about various modalities of treatment, so I will just skip these slides. All the techniques have been described very nicely. This is the technique which I use. And the background is when we started doing cultures, it was started by Lerner, Olson and Julin. And we faced the problems in the culturing because the culturing takes a lot of time, and it's difficult, expensive, cumbersome, and perhaps impractical so far as the practicing doctors are concerned. Then came the cell suspension surgery. It was started by Gauthier and Olson almost simultaneously. And I'm thankful to Dr. Sanjeev Mulekar, from whom I learned this surgery, which was an improvisation over the Olson and Julin surgery. We were talking about so many developments. The surgery made easy from culture to a single, 2-hour session, as Madhulika mentioned in her talk. And maybe it will be easier now day after tomorrow when we have another talk by Dr. Sumesh Gupta, making it, a bedside procedure. So we know the surgery. I will come to the cases straight away. So this was one of my, initial cases where
I did the surgery on the cheek, and you can see the lower eyelid also is involved in this patient. And this patient did not come back to me for follow-up. I called him. He sent me a photograph. So this is how it is. So in this photograph, you can make out that the eyelid, healed completely. And here we have some achromic borders, but otherwise the result has been reasonable. Now, this is the other young girl who came to us, very depressed, otherwise very beautiful girl, very well accomplished, very well educated, doing extremely well otherwise, but was socially very embarrassing for her to have this problem. So we operated upon her. Now, you see, the problem here is some areas have pigmented and so many areas have not pigmented, and leukotrichia is a major problem here. We operated upon the second time. Now, we were talking about, various difficulties in surgery. So difficulties in surgery, when you operate upon a vitiligo patient, the patient doesn't get all right. You don't have many choices, but with this particular surgery, you have choices. You can go ahead with the second session, even third session also. So she permitted us to do second session. And in the second session, what we saw, this is the final result of the second session. Now, at that time, when we were operating upon the upper eyelids, we were too much cautious because we were always worried about injury to the eye. We were never using any eye shields and all. So we were just stretching, and with the stretch, see, in this kind of surgery, you need a very good assistant. Your assistant is the key to the good results, because stretching the particular area where you are going to operate upon is, so much important to dermabrate the area. So if you would notice here in this particular patient, the pigmentation on the upper eyelid has not been that good. We operated upon another girl. She was just 10 years. And we operated in the first session. We did not get much pigmentation. In the second session, we could achieve, remarkable pigmentation. The patient parents were very happy. And she came back to us after another 2 years, and they came for leukotrichia. They wanted the leukotrichia to be corrected. So we took a chance and we did a surgery again on the areas where there was leukotrichia. And then she reported to get, absolutely all right after, the third surgery actually. Now, this is another gentleman who had generalized vitiligo. He was particularly concerned about his face. His children were growing up, and they were also being, subjected to some kind of discrimination. So he wanted himself to be operated. This was the result after the first surgery. And now I'll just show you the video of this particular patient's surgery, the second surgery. Let us see here. I'll just show you maybe a couple of minutes or 3 minutes of this video. This is the photograph I have kept there to show that this was the pre-surgery picture. And then for the second surgery, when he came, the first part, this side, left side, had recovered almost completely. And we moved ahead with the surgery on the other side. Yeah. So I will be demonstrating as to how we did it on the eyelid. Yeah, so this is the donor area. That's not important here. We will just go to the recipient area on the eyelid. I think it should be somewhere here. Yeah, so this is the eyelid being operated. Now we need a very good stretch actually. As I said, so the upper eyelid, when you are operating upon, you have to pull down the eyelid maximum, hold it with a gauze piece impregnated with the normal saline, and it should be held from both the sides below so that the eyelid doesn't get everted, because that's very important for the success of the, for the safety of the surgery. Now, this is, I think Dr. Sumit and Dr. Madhulika have already described these steps. So that is the suspension being spread now. And once we have spread the suspension, we put the dry collagen sheet. And after putting the dry collagen sheet, we will be putting, the gauze piece over there. Make sure that the open threads should not be coming towards the eye side. So it should be folded from below so that the threads don't enter into the eye. And then we cover it with the Tagardum dressing. So that is how it is done. So this was the final result, and very pleasing to see that even the eyelid margins have recovered. Leukotrichia is also kind of partially better. So that is how we treated the eyelids. Another patient, a young girl who came with a lot of hyperpigmentation. The problem here is not only vitiligo, a lot of hyperpigmentation, lesions on the eyelids, lesion on the lip also. And we operated her. Again, we had to give 2 sessions. And after the 2 sessions, now the upper lip also, is almost completely pigmented. So the trick in the upper lip is that you have to place a gauze piece under. You have to give tumescent anesthesia, and then you have to hold it. And if you can't hold the lip properly, then perhaps you need to hold the lip with the gauze piece itself inside the lip, so that you have a proper stretch and you can, abrade. See, the abrasion may take 5 seconds to 10 seconds only, but then you have to make sure that you are, when you start your dermabrasion, you are holding the lip properly, it is properly stretched, and there is no chance of it getting slipped from your, from the finger of your assistant. So once you have done it, after that, the process is the same. You have to spread the suspension and seal it with the dry collagen sheet. So about the leukotrichia, because we did a surgery here in this patient and that girl of 10 years of age for the leukotrichia as well. The theory is that there is antegrade migration of melanocytes from the root sheath. Then Ortone, they postulated that the antegrade migration from the melanocyte reservoir in the hair bulb occurs. And in 1995, Agarwal and Agarwal explained the retrograde transfer of melanocytes. After the surgery, what we do, that those melanocytes get transferred. So in February 2014, Dr. Prasad's team, they analyzed some data, and then they strongly supported the retrograde migration theory. But the problem here is it takes time. It takes about 1 year or maybe even more than 1 year to get the pigmentation in the hair. Now, this is a photograph of penile skin being transplanted. This is shared by a friend of mine, Dr. Munish Paul. I did not have a picture of mine. In fact, I lost pictures. Here, if you notice, the pigmentation is almost complete. If you look at the scrotum lesions also, scrotum lesions, they recover, they respond very well. Penile lesions, there is a practical problem because there will be expansion of the skin from time to time. So the trick is that you never give a tight dressing in this area. So after putting your collagen sheet, you apply the Vaseline gauze, and after applying the Vaseline gauze, you put a gauze piece over there, but don't put a micro pore tape over there. So leave it like that, and maybe because we know within 2 days, 48 hours, the melanocytes are taken up. Once they are taken up, then nothing can go wrong. Okay, so that's now another area. This young man came to me. He was getting married in 6 weeks' time. I told him I will not like to operate because the pigmentation will not come by that time. He said, "You go ahead, it's my luck." Very simple, very simple. See, it looks as if it's a big surgery. It took me maybe an hour and 10 minutes to do the surgery because the cell separation takes its own time. Otherwise, the actual operating time was hardly 20 minutes in this patient. And 5 weeks later, this is the result. Got married, and then he came back after 5 months, and after 5 months, this is the result. As Dr. Sumit mentioned, you have to be very, very careful about the dermabrasion on the nipple area. If you notice the pre-treatment picture, in the pre-treatment picture, there was depigmentation on the nipple area. But in the end, we have been able to get the pigmentation on the nipple area also. So you do have to operate, abrade upon this area, but you have to be very careful that you don't go deep. So this is the final outcome. Nobody can ever say that this patient had a vitiligo lesion. So to conclude, it's an effective method to treat difficult to treat vitiligo patients. The procedure can be done in the children also with proper counseling. It is possible to operate upon the previously operated skin as the texture of the skin is preserved. We can reoperate if the patient doesn't get proper pigmentation. We have done even 3 surgeries also in the same area and finally got the results. And the quality of pigmentation, as you also, is better, and color matching is generally good. Now we are doing a lot of cases under topical anesthesia only, and we can treat all kind of difficult areas, including fingers and including the palms. All these areas can be treated. We know that the donor area required is very less, and cobalt stoning doesn't occur, and the pigmentation that we achieve is lasting. The problems are that the technique is a little difficult to perfect, but with the advancements, new advancements, it is becoming more and more possible to learn this technique and make it, less cost effective and easier to perform. The other problem is that the pigmentation takes about 4 to 6 months time to get completed. With this, I end my talk. Thank you so much once again for your patient listening.
Thank you, sir. Thank you for the talk. I think we all have got a lot of great take-home messages. Moving on to the last talk, which is complications with vitiligo surgery by Dr. T. Salim. Sir is a senior consultant and clinical head at Cutis Institute of Dermatology, Calicut. He has over 20 publications and more than 200 presentations in various conferences. He is the international traveling mentor with American Society of Dermatology Surgery and an organizing chairman with ASICON 2022. In the past, he has presided over various conferences, national and international. His area of interest being dermatosurgery, pigmentary disorders, laser, and aesthetic dermatology. Over to you, sir.
Hi, I'm Dr. T. Salim, and glad to be a part of PigmentryCon 2022, and thanks to the organizing team. I'm going to discuss the complications of vitiligo surgeries and how to tackle these complications. As you all know, any surgeries have complications. Vitiligo surgeries, usually we start doing to manage the cosmetic disfigurement. At times, even if we treat the depigmentation, surgeries may end up in cosmetically unacceptable scarring. Here in this case, you have seen that there was a split thickness graft which was done over the large area, as well as there's a full thickness graft which was done over the mucosal surface. So these are really unacceptable. The priority of the patients change with time to time. Initially, the patient's concern is only the depigmented area, and he or she has to get it corrected somehow. But as we treat the depigmentation, the person is more concerned about the quality of the pigmentation, texture, and the mismatch with the adjoining skin. This is one of my patients, which I operated in 2003. And the patient was very happy at the end of around 6 to 7 weeks, where he started getting this sort of repigmentation. And later he came to me after about 2 years with these halo and the hypopigmentation all around. And he was a little unhappy about this part, and we had to retreat him. So this is what I've told you. Initially, patients would be really happy when you get some amount of repigmentation, but the quality is not that great. Patient may approach you to do something for it again. So here are the surgical therapies. All of us know that. I'm just going to go through some of the complications and how to tackle it. Punch grafting is one of the commonest method of surgical therapy in vitiligo. And the complications include complication at the recipient site as well as the donor site. Mainly, we are concerned about the recipient site. The commonest complication is cobblestoning, polka dot appearance or the sari dot appearance, static graft. The pigment doesn't move from the grafted skin. The perilesional halo, variegate appearance and the color mismatch, graft rejection or graft dislodgement, hypertrophic scars or keloids. So cobblestoning is one of the commonest things which we come across, mostly when we use large sized punches. And there might be color mismatch as well. So this is a static graft. The graft is there, you have grafted it nicely, but the pigment is not. Maybe the stability issues might be one of the issues. The polka dot appearance or the sari dot appearance is again a common issue when you take graft some area which doesn't match with the donor area skin. The donor side scarring is almost seen in almost all cases because you're taking a full thickness graft and it will definitely scar. So complications of punch grafting, how to manage, and basically the most difficult complication which we always come across is cobblestoning, and this can be treated or reduced or prevented by using punch of size 1.5 millimeter or less than that of diameter. When there is already an established cobblestoning, it can be treated by carbon dioxide laser ablation or a radiofrequency ablation followed by cellular grafting technique. This is one of our patients where the patient came to us, was referred to us for this particular deformity after punch grafting. What we have done is like we have ablated the whole area, and further we took off those cobblestone punches with the help of an almond, and further we spread the melanocyte cell suspension, and it is repigmented quite well and cosmetically much better than what she did before. Similarly, this is yet another case. And the variegate appearance and color mismatch can be treated by redoing the whole area with epidermal cell suspension. Sometimes even if there is no cobbling, you can get the variegate appearance of pigmentation even with the punch grafting. This is one such case. One area was treated with punch grafting. You could see that it is haphazard sort of pigmentation, depigmentation, hyperpigmentation, and hypopigmentation. This area was not treated. So what we have done is like we've completely treated the whole area. This is at the end of around 8 weeks. You could see that's almost completely pigmented. Another 4 to 6 weeks, it will completely repigment, and the quality of repigmentation is quite good. Coming to the complications of suction blister epidermal grafting techniques, hyperpigmentation, which might be usually transient, or in some cases it can be really permanent as well. Graft dislodgement and graft rejection is very common in suction blister epidermal grafting. Partial take-up leading to color mismatch, scarring, and infection. Scarring happens when you do dermabrasion beyond the limit, and even your dermal tissue is getting damaged. There you can get more hyperpigmentation as well as scarring. So this is one case where you could see that hyperpigmentation is stuck-on appearance. Definitely you need to treat these sort of cases. Again, another patient where you have seen hyperpigmentation. So these cases, what you could do is you can just dermabrade or laser abrade and take off all those grafts and let it repigment normally. So this is what we have done. It is repigmented much better, but there were two or two more spots which you could again redo, and the patient should get a better results. So treating the complications of section blister epidermal grafting, what you should know. So there is difference in the skin and the mucosal epithelium. So there can be the difference in the melanocyte load as well as the type of skin as well. So definitely if you could reduce the load of the melanocytes, it might not hyperpigment most of the time. Yet another case reason is uneven dermabrasion, which might be one of the reasons for the variable pigmentation. Some areas pigment quite dark when it is very deeply dermabraded. Some areas might not take up at all. That area might be depigmented, and some of the area might be normally repigmented. So this could be improved by doing an even dermabrasion. And securing the graft in position is yet another way to keep the graft in position, and in order to reduce the chance of graft dislodgement. So how do you reduce the melanocyte load? You can do a simple dermabrasion and replace the technique of suction blister epidermal grafting with a trypsinide graft or a cellular graft, so as the melanocyte load can be controlled. The variegate pigmentation, you can do an even dermabrasion, or another simple method would be a phototoxic separation technique, which would improve, which would give you a better graft bed to do your section blister epidermal grafting. Now, securing the grafts, you can use stay sutures as well as you can also use tissue adhesives. So trypsinized grafting is a simple technique where you can use trypsin to incubate, and you take off the dermal tissue, and if there is separated melanocytes over the basal cells over there, you can scrape off some amount of melanocytes and then you can place it. So this is one such case. We have just this immediately after, and this is the same patient. The pigmentation is almost similar to the adjoining skin. In other case, you could treat it with a cellular grafting technique. This is the epidermal cell suspension, which is being done before and after. Again, another case, epidermal cell suspension has been done, and it is completely repigmented at the end of around 4 months. And this is how you do securing the grafts. You can use these sort of stay sutures and then do your dressings. Similarly, you can also use, this is the same patient before and after, and similarly, you can also use cyanoacrylate, the N-octyl cyanoacrylate or N-butyl cyanoacrylate. These are the commonly used cyanoacrylates tissue adhesives, and you should apply it over the periphery, not over the graft, and it can stay there. And similarly, you can also use it over the skin when you use your section blister epidermal grafting technique. Now, what is phototoxic separation? So basically what we use is the 8 MRP 1% solution, which is painted over the depigmented area, and patient takes a exposed to UVA around 10 to 15 joules per centimeter square on the day before. The next day, when you just scrape off the upper layer, which is already being separated, would just come off, and this would be an ideal graft bed. So the epidermis can be easily removed at the level of basement membrane zone without much bleeding and creating an ideal graft bed, and dermabraders can be avoided here. Coming to the complications of split thickness grafting technique. So commonly it's a hyperpigmentation, peri-graft halo, milia formation when you have thicker grafts, color and textural mismatch, and hypertrophic scar. So this is a very common thing which we come across, split thickness graft. This whole area has been, you could see some depigmented area. This whole area has been treated with a split thickness graft. Some area you have milia, you could just extirpate those milia. So again, this is a color mismatch. This happens in some of the cases when you do a split thickness graft, but it might fade after some time. Maybe some of the cases it takes years to fade. Again, this is the post-treatment immediate hyperpigmentation, but this hyperpigmentations might reduce in about 1 or 2 years' time. Again, this is a perilesional halo. Again, split thickness graft, you could see that on the wrong site you have done it, and it's not exactly a split thickness, almost a full thickness grafting. It could induce a textural abnormality. So what we have done here is that we have removed the whole thing. We have initially, we surgically removed that particular area, then that particular wound healed. And after 2 weeks, we did a melanocyte cell suspension technique, and this was the final result. And mesh grafting is a rarely used technique. And the issue with the mesh grafting is that when you do a mesh grafting, the skin texture might not be great. It might have something like a checkerboard or a crocodile skin appearance. And this is how we've seen some of the cases where large area was treated using mesh grafting technique. And complications of tattooing and vitiligo, this is basically the color mismatch. When you put the graft, it might, I mean, the micropigmentation might be, it might be looking as similar to that of the adjoining area, but over a period, the pigment can change. Either it can migrate upwards or go downwards, and you could get these sort of pigmentary changes. And most of the time, patient doesn't like it and they want to get it removed. So this is what we have done. And this particular case, we removed it. We did around 2 sessions of Q-cis laser treatment. And further on top of that, after about 1 month after the second session, we did a cellular grafting technique, and it's completely repigmented, and patient is much happier. Again, this is yet another case which is already being tattooed, and the patient was unhappy. What we have done is that we just did 2 sessions of Q-cis laser, and we could take off all the pigment. And further, we took him up for surgery with the cellular grafting techniques. Coming to the complications of cellular grafting technique. Like any other surgical methods, infections are seen in cellular grafting techniques too, if you do not follow aseptic precautions. Complete or partial graft rejection, perilesional halo, transient hyperpigmentation, variable pigmentation are the commonly seen complications of cellular grafting technique. This is one case where it was almost a completely infected case, which came to us. We have treated with the amniotic membrane dressing, and it completely reepithelialized without any scarring. And further, we did a cellular grafting technique. So amniotic membrane can also be used as a primary dressing to prevent post-operative pain in cellular grafting technique. Infections are common if you don't follow aseptic precautions and proper post-operative care. Transient hyperpigmentation is seen with cellular techniques, whether you use a hair follicular melanocyte or a epidermal cell suspension, but this doesn't last for a very long time. Within about 6 months to 8 months, it usually comes down to normal pigmentation. This is again a hyperpigmentation. It's a transient hyperpigmentation, which is usually seen. It was a very large area which we treated. And you could come across partial graft uptake. Basically, it can be either due to some of the stability issues, or it can be due to your technical errors. And however, you could definitely redo that particular area and give complete repigmentation. Excuse me. Yeah, here what you come across is like when there are leukotrichia, especially following complications of cellular grafting technique, is that following cellular grafting technique, even after doing that, some areas the leukotrichia persist. So you need to treat this particular leukotrichia, for which you could take off those white hairs, and further you can transplant with the normal hairs, and that would prevent such a leukotrichia. Again, here also, if you have done the similar technique, initially we have treated her with a cellular grafting technique to improve the texture and the borders. To a certain extent, we could do that, and she was really worried about the eyebrows. We initially did the cellular suspension. There almost 50% got repigmented, and further we did a follicular transplant, and this particular eyebrows we could treat. So the perilesional halo is a common problem which is encountered, which can be avoided by, to a certain extent, by overdoing the borders. So when you treat an area, you overdo the borders to another 2 to 4 millimeters more, and you're going to spread the cell suspension in all these areas. And management of perilesional, so there can be a spontaneous cure, and intralesional steroid injections or tacrolimus applications may help in certain cases. And if nothing works, you can definitely think of regrafting as well. Here, in this particular case, what we have done is a regrafting, and it is completely repigmented. The recipient area, definitely what you come across is recipient area scarring. But if you have taken a very superficial graft, it will not give a very bad scar over the recipient area. This is one case which we have done around 1 year back, and this is the area where we have taken the skin for the cellular grafting technique. And now you could see that there is barely any any changes over that particular area. So if you're doing the grafting, maybe after a year, you can do it from the same area in order to prevent further scarring. Incomplete take-up may happen in certain areas, especially when you treat the acral area. They do not hold that pigment with conventional dermabrasion. So you can use a cryoseparation technique here. Call the patient on the day before and you spray cryo liquid nitrogen into the area of it's depigmented. And the next day when the patient comes, you will have the blisters formed already. You take off the blister fluid and into which you inject in your suspension. And this is the difference between normal dermabrasion method and cryoseparation. There is a transient hyperpigmentation which would come down in about 6 months to 1 year time. Instead of using cryoseparation, you can also use a defocus mode of carbon dioxide laser in order to create these pockets over this particular dermoepidermal junction. A continuous wave carbon dioxide laser at around 7 to 9 watts is used, and this is very useful in treating acral areas. This is how we use it. It's almost 3 times the focal length is usually used, and into which you injecting the suspension. So in conclusion, I would say that complications are inevitable in vitiligo surgery as well. Measures should be made to prevent the complications, like doing a peripheral area, overdoing the borders, and using proper equipments and proper techniques for the kind of patches and areas where you're going to do. And appropriate techniques suitable for the anatomical area should be chosen. Perilesional halo is a difficult problem even in cellular grafting techniques. Thank you very much. Before I conclude, I would like to invite you all to AXICON, the annual conference of cutaneous surgeons of India, which is to be held at Y3 Village, Wayanad Hills, Kerala, on 15, 16, and 17 September 2022. Please mark your date. Thank you. Thank you very much.
Thank you so much, sir. Not only do we have a good idea of what to watch out for, how to avoid and how to treat complications, we've also had a better idea of how the different techniques compare with each other in terms of pros and cons. We'll know more about all of these. We'll learn further in the panel discussion to follow. And I invite Dr. Somesh Gupta, sir, to lead the same. Over to you, sir.
Thank you, Dr. Pratik. And I am going to share my slides in a moment. Is it on the full screen or not showing full screen? No,
So it's
Not on
not
full
showing
screen.
full screen.
Yeah, sorry. So I have to share my window and then, sorry for this. Is it full screen?
You go to the presentation mode now from.
No, I try in Windows. I'm already in presentation mode.
Okay.
But it's not showing. This is the problem with my computer, I think. Just a minute. Sorry.
For a help, sir.
Yeah.
Sir, please open your presentation.
Okay.
Go in the full screen mode.
It is already in full screen.
Yes, sir. Now press the window button.
It's not showing window button if it is full screen.
No, sir. Control, Alt, and there might be a window button on your keyboard.
Okay.
Press
Control. Still not showing.
So you have to press the window button, then you might be able to see the taskbar from where you can go to the Zoom.
Window button. Yeah. Right.
Yes, and now click on the Zoom button. Now try sharing your screen.
Right. Got it.
Yes.
It's showing invalid.
Sir, either share the first screen.
Yeah. So, sir, on your right hand side down, yeah, just click on that.
No, I clicked it. It is full screen on my computer, but not for you.
You can click on the slideshow on the top and then you can start.
I did that also.
Yeah. Okay.
And from beginning you
from
can.
beginning.
Yeah, I did it. It is full screen on my computer.
Dr. Sumesh, I think we can go on this only.
Yeah, I can go on this. Yeah. Right. I can go on this. Okay. Sorry for this trouble. Is my slide moving?
Yes.
Okay, great. So thank you all panelists. I enjoyed watching your talks in great detail, and I think many of the questions which I had picked up already clearly conveyed the answers of them. So maybe I will restrict to some tough questions to you, maybe which will make you uncomfortable a bit, but you are all great experts. So I'm confident that we will come out with some answers of tough questions. Okay, so we have a great panel with us, Dr. Deepak, Dr. Madhulika, Dr. Sumit, Dr. Ashik, Dr. Mukesh Girdhar, and Dr. T. Salim. And I'm amazing results which you have shown. So my question is, do you show your best results in vitiligo surgery in your presentations and to your patients, or you also show not so good results? So each one of you can answer. You know, this leads to high expectation from the participants' point and also from the patient's point of view.
Yeah, so shall I take it?
Yes, sir, please take it.
Okay, so I always tell the patients that we show you the best results to make you understand our procedure. But I tell them that there are about 30% failures. Maybe when we are working on the segmental, there are maybe 10% failures. Otherwise, we expect about 30% failures. And failure means, I also tell them, for us, if there is 70% pigment, we call it success. So maybe even lesser than that. So it does happen. It all depends upon your luck, the activity of the disease. So that helps me in counseling further and inquiring about the stability again. Because sometimes they are lying. When you tell them that the biggest reason for failure is the instability of the disease, then they come out. Then they come out and give the history. Well, doctor, the disease, last progressed this much months back, actually. So you are able to select your patients better that way. I think the bad results, one of the biggest reasons is the lack of stability.
Right. And any technical failure? Yeah, Madhulika, go ahead.
So, sir, we have a presentation, a PPT, which is present at the clinic, which is shown to all the patients when they are requesting surgery or when we are trying to convince them from surgery. which shows good results, partial results, as well as complete failures. And then the onus is on them to make an informed decision whether they still want to go in for it. So in that way, we have explained and been clear from our end completely without disillusioning them with respect to what they can expect.
That's very wise thing to do. Well, we can also do the same in our presentations to our delegates, isn't it?
Yes, sir.
I also don't do it. I confess about it, but yes. Any other panelists?
Yeah, can I answer this question?
Yeah, Deepak, yes.
Yeah. So, as we all know, the vitiligo patients are already on the lower side of hope, means they have lost most of the hope and they expect results from the dermatologist. But even if they say in the consultation part that we want 100% results, but even after that, we know that even after that, after doing the surgery, even if they get 60, 70 or 80% of the results, they are very happy. However, when they get 80% of the results, after that, they be not that happy like they were during the consultation times. So what in practice, what we do is we show the best of the results, and during the consultation itself, we say some patients don't reach to that level and they get some lesser results, say about 70 to 80%.
Right. Salim, how you deal with unrealistic expectations?
Yeah, I agree with the previous panelists, which they have told. Basically, I usually don't operate on patients who are unrealistic or parents who are unrealistic, because it's really tough. And I always show them the best possible results and the worst results as well. Especially when I deal with a vitiligo vulgaris or a necrofacial vitiligo, we would always say that if there are chances, even if you get more good repigmentation, there are chances of your pigment going off, because you should take it as a biological camouflage rather than a permanent pigmentation, especially in cases of vitiligo vulgaris, not in segmental vitiligo.
Right. Thank you. So, Ashik, are you there? Is Ashik?
I think so. Will join in some time.
Okay, no
He'll
problem.
join back.
Okay, no problem. So patient selection and stability, inducing stability, lesional versus disease stability. So this is a patient of acrofacial vitiligo. Same patient, we did mini grafting test on the hand lesion and mini grafting test on the eyelid lesion. So how would you like to go ahead with the eyelid lesion transplantation and refrain from doing it for hand lesions? You believe in lesional stability or disease stability? Any of you?
Personally, I would consider overall disease stability rather than lesional stability.
Okay. Even if the patient says that my eyelid test is positive, so please do it on my eyelid.
So I wouldn't take the chance.
Okay. Any other panelists?
Hello, hi Somesh. Ashik here.
Yeah, Ashik, you joined.
Sorry, yeah.
Sumit also, Sumit is there?
Yes, sir.
Okay. Yeah, go ahead, Ashik.
Stability, I would actually prefer a universal stability rather than a lesional stability. But unless there is a compelling pressure from the patient, something like a function coming up or something, and we take a calculated risk explaining everything in detail.
Okay.
But lesional stability alone is not a preferred way to go for me, from what I felt.
So, Sumit, what do you say?
Sir, I also believe the global stability as a more reliable criteria. However, there have been instances where patients are aware of some patches which are older and which are much more stable, and it's also evident from the clinical examination. I frankly do not do the punch test as a regular practice in my practice. And there have been instances that I have been able to successfully cover some patches and failed at covering other patches, which I was aware that this is going to happen, and the patient was also made aware of the same. Also, in such patients, I like to give a cover of an oral mini pulse around the surgery, starting before the surgery and maybe lasting about 1 month later to the surgery.
Okay, we will come to that also question. But if you look at carefully, we had applied 4 grafts and 1 got depigmented. So if you do mini grafting test and you get this kind of result, what is the inference? 1 graft depigmented, 3 grafts showing perigraft spread.
Mathematically, it's a 75% success.
Most of the time, I believe this. What is going to happen is the rest of the 3 are also going to probably depigment in coming times. And
Why you presume that?
Because I have seen this to happen in some of my patients, not in a punch graft test, but in some patients when there is an initial repigmentation, then they tend to lose pigment at certain areas which are slightly more unstable, and then it all depigments again.
Right. So my next question is to Madhulika. Apart from historical stability that is stable for 1 year, what other features you look for to determine the stability?
So the most important one is definitely relying on the patient's history with respect to any new patch which has been observed in the last 6 months or more. Along with that, yes, I do check out the margins of the lesion, whether they are well defined or they are a bit ill defined and hazy. So in which case I would actually put them on OMP for a couple of months just to be absolutely sure of at least induced stability. So yes, these are my 2 main criteria, sir.
Right. So agree that these 2 patients had segmental vitiligo. One had indistinct margin and the other has well-defined margin. So the response is so varied in both. There is poor response with ill-defined margin and good response with well-defined margin. So thank you for pointing it out. But this has come second time, the peri procedure immunosuppression in high-risk vitiligo, that is acrofacial or generalized vitiligo. Dr. Mukesh Girdhar, do you start some immunosuppressive ahead of surgery and continue for some time in some patients?
Very, very rarely. In fact, I used to do it earlier. Now I try to be very sure about the stability of the disease before I take up the patient. Number one, segmental vitiligo, most of the times we can be sure of stability, but in the generalized vitiligo, other areas, when we are not sure, we want to inquire about it. And if we have doubts about the stability, we want to treat the patient first with the medication. We want to counsel the patient that the patient should not rush up with the surgery unless there is a marriage impending after 6 months or so, and they have finalized the date. It's my favorite question to the young people that please don't finalize the date of the marriage without asking me when I'm treating such patients. So I am never in a hurry to operate. Sometimes, in a rare case, I have put the patients on OMP immediately preceding the surgery, and I have persisted with the OMP for the next 2 months' time. I have seen many patients where we have done surgery, the patient achieves about 80-90% pigmentation, and suddenly on the next visit after 2 months, you realize 40% of that pigmentation is gone. So, and that was all because of stability. Unfortunately, there is no marker for us to be 100% sure about the stability. So whenever in doubt, first of all, you don't operate. If you are forced to operate, then maybe you have to give some kind of immunosuppression.
Right. So induce stability. Madhulika, you use this word, induce stability. Do you induce stability?
Sir, not often. I would prefer to wait out at least 6 months when in doubt. But like Dr. Girdhar just mentioned, if there is an impending event where it has to be done, where we don't have time, then yes, probably only in those scenarios, which is less than 10% of my practice actually.
Okay, Salim, this question to you, that even with the patient saying that last 1 year, no progression, no new lesion, no kibnerization, in acrofacial disease, the outcome is not as expected many a times. So is it not an indication for starting a drug like cyclosporine 3-4 weeks before the surgery and continuing for few months?
Definitely, sir. I actually, in few cases, I do that, especially only in case of acrofacials or a vitiligo vulgaris, only not in segmental vitiligo. Sometimes there are, because the majority of the studies say that most of the time the pigmentation is about 50 to 60%. So why not take a chance for another 40%? It would be better you start with one of the immunosuppressive agents, preferably cyclosporine. There are few studies which has already been published in this line. So I usually use it, not in all cases, but some of the cases definitely I do use it.
Right. So I call it peri-procedure immunosuppression. Yes. So that's good. Okay. So you are happy, patient is not. This is a very, you discuss, many of you discussed in your presentations. This margin, even if you do derm abrasion all around 1 to 2 millimeter beyond, and still there is variegated pigmentation, the achromic fissure is sitting on your head and patient's mind also. How you deal with this? Any of you?
Can I answer this question?
Yeah, sure, Deepak. Go ahead.
Yeah. So I think in these patients, NBUVB works better, and over the period of 3 to 6 months, it can give rise to almost complete pigmentation. But even if after 3 to 6 months, this perigraft halo or a peri-halo ring is there, then micro needling technique would be of great help in these cases.
So how successful these techniques are? Like, can you give us a rough idea what proportion of patients are going to help?
I think around 60 to 70%.
60 to 70%, that's a good figure. Okay.
The help of NBUVB plus needling.
Right. Thank you.
To add to that, so what we've done, obviously NBUVB forms a very important aspect here with treating achromic halo, but needling with 5FU has also helped in these achromic lesions. So that is something which I routinely use with good result.
Right.
Okay. Thank you.
For me, I would say if the patient is really concerned, micro punches, MPEG, 1.5 mm punches, not all one go, the bigger ones first, like that, and along with that, a support of push of NBUVB really works. NBUVB is the kingpin.
Thank you, Ashik. Yes. So, but even our experience is that even with NBUVB, even with Excimer, only a small number of patients are, we have just sent a report in IJDVL accepted for publication that Excimer helped only 20%, less than 20% of the patients in avoiding the second procedure when there was incomplete repigmentation with the first procedure. So maybe we haven't done needling, so we should try needling. Okay. Do you combine procedures, any of you? And if yes, which procedures you combine? In the same session or in different sessions?
We combine non-cultured epidermal cell suspension along with follicular grafting for the like the eyebrows and the vitiligo around the eyebrow area.
Different areas may require different procedures which are successful in that particular area. For example, if you're treating the lip, then suction blister grafting has to be added to the list along with NCES for any of the other body areas. If we are treating the acral areas, especially the fingers, I would rather do a mini punch grafting there. So yes, it can be combined in the same session as for the area to be treated.
Right. Okay. In the same page, sometimes do you combine sequentially different procedures, any of you?
Yes, for me, for example, that boy which you just showed, no, the previous one, the perilesional. So such people actually have this extending into the lip also sometimes. So what I do is invariably I start off with NCES, And I tell them that we may have to do blister for the lip later. And those areas which did not take up well, I end up in doing punch. So I have quite a lot of patients whom I have done 3 procedures. So very late with the spacing, not on one go, no, never on a same sitting.
Right. Okay. Great. Thanks. I request audience to please post their questions, queries, comments. We would like to take up now during the panel discussion. So this is Dr. Jung, who had done a fellowship with us long ago, and he's from Korea. So he did NCES and then did extremely fine micrograft, punch graft taken from motorized this motor, and to achieve the complete repigmentation. So Deepak, how you put these micrograft, extremely small graft on the recipient area? Is it easy to handle when you take it with the motorized punch?
So it's a difficult process. Like the depth is very important when we have to take the graft from the recipient area. So if we the depth should be proper in treating these cases.
Now, how you put the graft, with the help of a needle or with the help of a forceps?
No, we do with the help of 0.9 mm punch, not less than that. So we do it with the help of forceps.
With the forceps. So what Dr. Jung suggests that it is not important to bother about the upside down or like the side of the graft. If they are so small, so tiny, 0.5 mm graft, that you can put them whichever way you want, and there will be repigmentation. Unlike punch graft, where you have to keep the epidermal side up, outside. So this is again a good technique. He has been advocating this for now quite some time.
My only concern with this technique was that, sorry to interrupt, that even if there is a smaller punch size, sometimes some grafts will go epidermis down. So can that lead to sebaceous cyst or epidermoid cyst formation?
They haven't found. They did a comparative study in which in one half they put the upside down the graft whichever way they go, and on the one side they did proper grafting, and they found no difference. They published it in Journal of Dermatology. Dr. Mukesh, yes.
Yeah, I was just trying to look at these 3 pictures. See, if you see the middle picture, there's a lot of crusting on the neck and on the upper chest. See, that makes me concerned because we are putting so many, points of little deeper injury on the upper chest area, which is very keloid prone area. So that is what my concern was. Number 2, coming to the end result also, I mean, it doesn't look to be texturally, or there is no uniform kind of pigmentation which you will normally get with NSES. So truly, I'm not very, very impressed with what we have achieved in this particular patient. I'm sorry.
Yeah, agree. Yeah, yes. So always,
if I may come.
Yeah, Sumit, yes.
Yes. Sir, I don't know, sir, whether a lot of other panelists or experts share. We get a lot of publications showing these kind of results, and they label it as refractory vitiligo. On the very first instance, from the very first look, this kind of patient in my practice, I would think that this could respond very nicely with just phototherapy. And maybe the procedure is done there just to speed that up, but maybe we can get the same kind of result just with phototherapy in a lot of patients or photographs that we see in a lot of publications. That's my honest opinion. I don't know what you.
Yeah, right. Yeah, maybe sometimes the decision to go for surgery is influenced by some bias, and I agree with you. Do you advise post-procedure phototherapy or sun exposure with both tissue grafting and NCS? Any of you can take it.
Yes, sir. I do
yes.
most of my procedures.
So what, phototherapy or sun exposure?
Phototherapy. Phototherapy starting 3 weeks after the procedure. It kind of helps to speed up the pigmentation as well.
Okay. Okay, Sumit, you were saying something?
Yes, sir. As a routine, I believe if the patient is from a far off area with no facility of narrowband UVB.
Okay.
The problem with the
Then
phototherapy.
either just
Yeah, sorry. Go ahead, sir.
just a simple sun exposure, mostly for face, and for other areas, preferably a puva sol, oral puva sol mostly. And if the patient is from a nearby place, we can use the targeted phototherapy. Or if the area is slightly big, we can use the narrowband UVB phototherapy. That's how I do it. And we typically start it after 2 to 3 weeks of the surgery.
Okay, Deepak, you saying something?
Yeah, I was adding that even if the phototherapy is started just after 7 days after the surgery, the problem is that some lesions tend to hyperpigment. And even after 6 months to 1 year, they don't tend to normalize and mix up with the surrounding area of the skin. So what we do is we wait for around 3 months. And even after 3 months, if we think that there is less of pigmentation, then we start the phototherapy.
Right, it makes sense. Okay, but generally I advise my patients for sun exposure to facilitate the repigmentation. Okay, so this is a bit of busy slide, but I want some of you at least tell which procedure is your preferred choice and which procedure you will never do. Maybe I start with Dr. Ashik.
NCES, blister, and punch.
These you do?
I regularly do.
And which you never do? Which you never do?
SSG never. Follicular transplantation, no.
Okay, Salim?
Yeah, I do cellular, both NSCS as well as follicular combinations we do. Similarly, punch grafts very rarely, especially for the palms and areas like that. And both split thickness grafts as well as blister proof graft, both I do.
Okay. Okay, Dr. Mukesh? I think you do only
most of my almost all my patients are NSCS patients. Rarely I put a split thickness graft.
Okay. Okay. Who does this therapeutic wounding, local excision, micropigmentation?
Yes, sir, we do.
You do? Okay.
So, like I said, for
yes, Madhulika, you do from on the other side, right side.
So, therapeutic wounding, like I said, in cases of achromic halo, that is something I routinely use. Local excision in case of a vitiligo patch on the inner aspect of the lower lip, or a really tiny patch. It's always better to excise it rather than treat it with any other complicated modality. And even micropigmentation, for the angle of the lips, maybe a very tiny area, or somebody who requires immediate camouflage and cannot wait for the surgery. Yes. So at some point of time, I have used all of these modalities.
Okay, right. Anybody is doing Jodhpur technique? It's such a simple and nice, elegant technique.
Planning to do, but not yet. I haven't got a ideal candidate for that.
What is the reservation?
Sir, I've tried Jodhpur technique in the initial days. Somehow I didn't get that kind of outcome that was desired. Mostly it is an incomplete pigmentation or a very variegated type of pigmentation and irregular texture also. I believe it has to do with the same kind of thing that we were talking about. Some of the grafts are not in the epidermal side and dermal side. So maybe that is the reason, but it's a good technique for a resource setting. The other thing, sir, for excision, I believe scrotal patches, scrotal or genital remnant patches, I believe excision is the treatment of choice for if they are very small, particularly in the scrotal skin, in my opinion.
Thanks. So this is a recent JAMA dermatology meta-analysis. It says tissue grafting gives greater success rate than cellular grafting. How many of you agree to that? Do you think it is the case?
No.
In the long run, we tend to feel happy that the punch grafts gave us the best results than melanocyte.
Oh, Okay.
Sometimes, some patients who come back after 10 years and kind of. So, but then when we choose the patients right and do it wise, I think I would still say that cellular grafting. But it's subjective. I don't know how far we can put it across on a graph.
Right.
I think proper selection of technique is
exactly.
Yeah. So because this is not a randomized data, so they did not take into consideration segmental numbers in each category, disease duration, stability duration, body surface area, size of the treated patch, concurrent medical therapy. So we pointed it out in the JAMA itself that the vitiligo is such a complex disease and it is too simplified a meta-analysis. Because it's you cannot compare uncomparable. Yeah, Sumit, go ahead.
Another thing, sir, I believe this cellular grafts have a slight learning curve, and a lot of studies that are typically done, for instance, as thesis, which are very well conducted studies, but are done by someone who has not sort of have a great experience in that procedure. I believe skill also has a role to play in having good result vis-a-vis tissue graft, which have comparatively lesser of a learning curve. That's what my opinion is. That what personally I also faced when I published my study.
Right. So also when we choose tissue grafting when the patch is small, we choose cellular grafting when the patch is large, and large patch is unlikely to repigment completely as compared to small patch. So there are so many variables which have to be, you need a multivariate analysis, which they didn't do. Okay, I have a question from Dr. Pooja Mandalia, that should we combine post-procedure phototherapy in all surgical patients of vitiligo, and if yes, for how long? Salim?
Yeah, actually, when you ask that particular question, I'm of the opinion that for segmental vitiligo, or in some of the cases where you are really sure about the stability, I usually don't start on phototherapy for at least for first 6 weeks to 8 weeks, because like one of the panelists said, there is a chance of immediate post-inflammatory hyperpigmentation in these cases. But definitely, if it's a punch grafting, if it is a non-segmental vitiligo, I always do start with a regular phototherapy right from another 15 to 20 days once the lesions are completely healed.
Right, thanks. I think we also discussed this earlier. Okay, tissue grafting versus cellular grafting. When, where, why? Maybe Deepak start first.
So I prefer tissue grafting for the angle of lips, preferably, and the areola area. And for the larger areas, I prefer the cellular grafting. Tissue grafting in the form of follicular unit grafting I use for the hair-bearing areas, especially eyebrows, beard area, and the genital areas.
Okay. Ashik?
Start doing tissue grafting, and finally you will end up with NCES and cellular grafting. So learning with tissue, not the other way around, I would advise, because that learning curve, as I think Deepak said, is difficult. So, but you get the feel of things by starting tissue grafting. But then for me, about specifically asking the question, I would say lip, I do only blister grafting, and the other things are the same.
Okay, concha and pinna?
Melanocyte, NCES.
Okay. Anesthesia for donor site in suction blisters. Salim, I think when you showed you mentioned recipient area for donor site, I get by mistake.
No, it was a donor area. I'm really sorry.
Yeah. Okay, anesthesia for donor site in suction blister. Again, Deepak, do you give any anesthesia?
Yes, we do give anesthesia at the donor site in the suction blister.
Which anesthesia?
The plain xylocaine 2%.
Achha, but the blistering process is long. Does the xylocaine effect last that long, or you need to mix with bupivacaine?
Yeah, in some cases we prefer if we think that bupivacaine should be added, but usually in the later part of the blister formation, the patient do complain.
Okay. Okay. What size you use for mini grafting? Which punch size?
For motorized punch grafting, we use, I have already told, we use
No,
the
not motorized, manual ones.
manual punches we do by 1 mm punch graft. Sharp punches 1 mm punch.
Is it easy to handle those small grafts?
Yeah, 1 mm punch size are easy to handle.
Okay, right.
I am for 1.5, both donor and recipient.
Okay, right. 1.5, huh?
Yeah.
Both. So it's a good mix because it is easy to handle 1.5 and it doesn't lead to much of cobblestoning.
Yep.
Okay. So those who do split thickness graft, this is not acceptable anyway. Somebody did it. Is this acceptable?
No, not at all. Sir.
Not at all.
Because, yeah, it's basically the thickness of the graft. It's not a thin epidermal graft, first of all. You need to be a little more thinner. If your hand really doesn't work, I think you can go for the motorized dermatomes. That gives excellent, very thin grafts, actually. And second thing is that there is a chance that the graft might shrink. So you can definitely cut it into pieces and do grafting as well instead of using large. That has happened with the first photograph which you have shown. There was a graft shrinkage as well as there's a thickened check-on appearance as well. So these things would be better on if you use a very thin epidermal graft without any dermal component.
Yeah, so somebody did this. We had to redo everything, dermabrade everything, and then do NCS in this patient. Okay, this was using motorized dermatome ultra thin. Still, it is not a match with NCS. You know, non-cultured epidermal cell suspension. Okay, so hair transplantation for vitiligo patch. Do you do it only for leukotrichia or also for vitiligo patch? This is Amrinder has done for vitiligo patch and leukotrichia both, treatment of both. So Deepak.
Yeah, so we do for both, for hairy bearing areas and also for leukotrichia. So in these cases, usually as non-cultured epidermal cell suspension won't alone will give good results. And if we do only FUE, then those pigment can repigment the skin also. So it would be the preferred.
Right. Anesthesia for NCES, Madhulika?
So if it is just for smaller patches, I prefer to do it under surface anesthesia only. But if it is a really anxious patient or if it's a larger area, then I will use Xylocaine 2% as well.
Okay. Dr. Mukesh?
Yeah. So in the acral areas and the skin is thick in a particular area, or if there is a large area, I use 1% Xylocaine. I don't use 2%. Otherwise, most of my patients are now managed on the topical anesthesia.
Right. Deepak, when you said that punch grafting donor area don't use adrenaline, why you said so? Why there any reservation? Because you are having a lot of bleeding when you are using motorized punch.
Yes, yes. So I've told that we can use the adrenaline in lesser concentrations at the donor area, and we don't use the adrenaline for the recipient area.
Yeah. Recipient side, nobody uses them. Yeah, right. So which technique you prefer for obtaining graft from NCS? Madhulika already mentioned she just used razor blade. Anybody else? Salim?
Yeah, I use a modified silver's knife where you have a razor blade on a handle, as well as I also use a motorized dermatome.
Okay. Sumit? Sumit, you are mute.
Sorry. Then, I mostly use the Silver's skin grafting knife, as Dr. Salim said. I have on the occasion used the motorized dermatome. However, I don't think it's worth the investment, frankly, because that's a skin one can learn.
Right. Dr. Mukesh?
I use a very basic dermatome with a Gillette blade to take the donor areas.
Right. So you don't need, I agree with Sumit, you don't need some hi-fi equipments or instruments because just taking a paper thin graft heals without scarring and as Salim mentioned in his talk, that we can use the same area to take the graft for the next session, because it is equally, it is just a very, very thin tiny scar with hardly any deeper scarring. These are donor areas after healing. Okay, so we are left with very little time. I want all of you, any of you, to give us tips on procedure fine tuning, standardization of procedures, shave biopsy, or your tips to our audience. Just one or two tips from each panelist, which he or she found very useful in the practice. You can start. Ashik.
For punch grafting, I'll say talk about the punch grafting. Handling punches. There is a recent paper which we published in JCAS also. Use a +2 diopter spectacles on top of. If you are wearing a specs, you use a +2 over it. Or if you're not with the spectacles, just use a +2 reading glass. No, that is all you need. You don't need a loop and anything to handle these graphs.
Okay, right.
There is a paper in JCAS in the recent issue.
Okay, thanks. Salim?
The recipient site preparation for the acral areas I had shown you. This is the defocused mode of carbon dioxide laser is something which we are using very often. The advantage is that unlike the cryo blistering, you don't have to call the patient a day before. So initially the same mechanism you would get, a pocket would be created at the dermoepidermal junction by you use a focal length around 2 times that of the normal focal length, and you are doing a continuous wave carbon dioxide lasing. Then it creates a pocket at this particular level, and to which you could just straight away push in your cell suspension. This is one way you could treat the the acral area where the regular dermabrasion might not take up very well.
Dr. Mukesh?
When operating upon the upper eyelid specifically, if you have access to, use an eye shield. Eye shield makes you much more comfortable. You feel sure that you will not end up harming the patient's eye in any way. Number two, that also makes the patient comfortable, that your surgical hands may not, because otherwise they are tentative. Another thing about the eye shield, if you are going to operate upon both the upper eyelids together, don't put the eye shield in both the eyes together. The patient is going to feel very, very claustrophobic. So use it in one eye only, and you must use it whenever possible. Whenever you need to go up to the lid margin, use an eye shield.
Can I add one point to what Mukesh said?
Sure, sure.
Use local anesthetic drops, eye drops along. That makes the patient absolutely comfortable. You can use it one drop. It anesthetizes in a few seconds, 30 seconds to 1 hour.
Okay,
in 1 minute.
Very important. Thank you.
Thanks.
Kulika?
So I would like to say that in NCES, dermabrasion is one of the most important steps, and the level has to be perfect in order to get a good result. So always take the help of an assistant who helps you with stretching of the skin before you do your dermabrasion. Otherwise, you'll end up with a deeper level or even tears on the skin. The patient has stretch marks, for example, in the same area. So yes, that is my tip for the day.
Very important. Stretching in maybe all 4 directions makes it much easier. Okay. Sumit?
So 2 things. I believe the rate limiting step in non-cultured epidermal cell suspension transplantation is the cellular separation. And I believe the reasons for that are 2. One is the thickness of the graft is not that much appropriate sometimes. And if it is a thicker graft, it is unlikely to get trypsinized well. The second is the potency of the trypsin gets lost when it is repeatedly frozen and thawed. So it's better to limit those frozen and thawing cycles by storing the thawed trypsin in the first instance in sterile aliquots and storing them in a freezer. The second thing is, as Dr. Madhulika said, there are instances when there is a stretch mark kind of an appearance or a very atrophic kind of appearance on patches, and when we are abrading it, So invariably it leads to tears. So whenever that tear happens, which is inadvertent, we can put those dermal pieces, which we get from the separation of epidermis and dermis, and it heals very well without leaving any scar.
Interesting, interesting. Deepak.
Yeah, I would like to add that during tissue grafting techniques for the larger areas, uh, reducing the surgical time can increase the viability of the grafts and ultimate result. So for that, we can do likewise, like we don't place the graft in the graft holding solutions and directly place the graft on the dorsum of the hand on the person who is placing the graft. So in which that way we can reduce the time.
Excellent. This is similar to what DHT, Pradeep and Arika had reported for hair transplantation.
Yeah.
Don't put it outside the body and just put it inside the body immediately after they come out in their familiar environment. Thank you very much. All of you enjoyed every moment and your expertise is like amazing. Thank you so much. And thanks PigmentRecon organizers for giving us the opportunity to discuss so many issues which we rarely discuss. Thank you.
Thank you, sir. I would request all our doctors to please keep their webcam on for just a few seconds more so that the tech team can take a group photo of all of us.
Okay.
New concept. Having said that, I thank you all for this amazing discussion. A lot of us have not started vitiligo surgery because of simple reservations about complications or how to procure the equipments in the first place. So this was really a one-of-a-kind workshop. Our audiences, I request you all to join us again in an hour's time for the afternoon workshops. Thank you all the doctors once again.
Thank you, and thank you to the tech team as well. Thank you, everybody.
Thank you. Thank you. You have been organizing it well. Thanks.
Thank you.
Thank you very much. Thank you.
We can now close this. Thank you all.
Can I leave the meeting?
Yes, sir. Thank you.
Thank you so much, everybody. Good luck. All the best.
Wish you the same.
See you, Somesh.